So good morning everybody. For anybody who doesn't know me, my name's Carolyn Downs, there's my nameplate there, and I will be chairing the meetings going forward. Following our meeting of last month, you will all be fully aware of the new arrangements for the chairing of the board. As I said, I am going to chair the meetings going forward, but I'm not the chair in the terms of the previous role, and we will be actually splitting up the responsibilities of the chair between the remaining 4 non-executive directors on the board. My understanding is that a further non-exec director post is in the process of being advertised, and we'll be delighted once that post is appointed to sooner rather than later, would be our preference. And that person will have a responsibility for finance issues. But in the short term, I will cover some other finance issues with Obi and Chris, and I will also cover workforce. Tony Hunter and Julie Garbutt will be dealing with out-of-hospital mental health services and commissioning. And Claire Gerarda, who sent her apologies today, she's on her 2nd honeymoon, and Claire will be leading on clinical issues. So that's how we're going to split up the responsibilities in the short term. The board is due to be reviewed anyway in a year. So by the time you start doing the review, it's got to be reviewed by a year from now. So by the time you start doing a review, by the time you recruit a new chair, there is absolutely no point whatsoever. And we fully support, as the board and the non-executives on the board in particular, fully support the decisions that the Minister has made on this issue. So I hope that clears the matter up, and we just get going with the meeting now, as long as that is okay with anybody. I'm really happy to take questions at the end of the meeting on any issues that you want to raise. Right, so we'll crack on. As I say, we have apologies from Dame Claire Gerarda and from Dr. Simon Mackenzie. Will be welcoming, I don't think she's here yet, Becky Sherrington, who is the Chief Executive or Chief Inspector for the Jersey Care Commission, who will be coming to do a presentation. That's timed for 10 o'clock. I'm very happy to say hello to Minister Tom Binney and to Deputies Barbara Ward and Andy Howell, who are with us today as well. So good morning, and good morning to everybody else who's here as well. Right, so we'll crack on. Oh, Andy, thank you. Andy Weir is at an inquest this morning, so he gives his apologies. And Patrick is expecting at some point a very urgent and important call, so he'll just leave for that and then come back in. Okay, so on that basis, any declarations of interest from anybody? No? Excellent. The minutes of the previous meeting are here. I have cleared those as the chair. Has anybody got any issues with the accuracy of the minutes? No? No. And the matters arriving and the action tracker, looking at those, I think all the issues are being dealt with. They're either on a future agenda or this agenda, and so I think those we can just basically pass on as well. So on that basis, out of order, I've done my chair's introduction. I did that to start, so that's done. So I think on that basis we can move straight on, Chris, to your Chief Officer report, and at that basis we've made a lot of time up already, and so we've got time. Right, we've got time. Yeah, we can grill you.
That's good. Lovely. Can you hear me? You can. Okay. Thank you very much, Karen. As I say, I will just highlight some points in my report and sort of remind everyone that what I've tried to do at least is to try and cover off in very summary form the sort of key issues that we will discuss in a bit more detail later on in the agenda, and indeed some other things that are not on the agenda. But I just wanted to highlight that obviously our staff engagement and cultural programme continues and been led by myself and Cheryl Power. And just a couple of things. It was a very successful sports round which had the title The Voices of Women in Healthcare, It was attended by over 30 staff, and I think I wasn't there myself, unfortunately, but I've had some very good feedback from the discussion that was taking place there. This month, or last month, this month I held my Chief Officer's Teams talks at actually Five Oaks, so sort of outside broadcast. Five Oaks, for those of you that don't know, houses our central stores, our sterile supplies department, our laundry, and I obviously met staff there and held the Teams talk from that venue. You'll see in my report there's a list of other staff engagement events and achievements, all equally important, but I do want to raise just a few things there. The Nutrition and Hydration Week, clearly hugely important, led by Jessie, our chief nurse. These are key for those of you that are nurses or indeed clinicians. You know how important this is, and I think that was a very successful event. We have a new dedicated breastfeeding support clinic that was launched, which again is very good news, much needed. And HCS colleagues supported the healthcare assistance recruitment campaign. I popped down to the education centre at the General Hospital and met people. It was well attended. I think, Bill, some 40 people. 35, sorry, not exaggerate. 35 people attended that, showing interest in becoming a healthcare support worker, healthcare assistant. So we're hoping, Bill, aren't we, that some of them will follow through on that, and we...
We've just started to process. I think Sally Cook and the recruitment team have already begun to process 7, and there's a further 2 cohorts to process more.
Brilliant. And of course, this area of appointing healthcare assistants has been a challenge for us, a lot of competition in the market, so to speak, for people that do that work. And also the PICA survey results, which we heard last month, were celebrated amongst HCS employees. Patient experience, pleased to report that there has been a noticeable decline in the number of formal complaints and in the number of compliments that we receive. And I think that reflects, we believe it reflects, Jessie, don't we, the shift in the commitment to address concerns at an early stage so we can resolve those issues before people have to resort to a formal complaint. So we've seen in Q1 those numbers coming down. The patient advice and liaison service, which I believe ministers and the health minister and colleagues visited, I can't remember now, a few weeks ago, and met the colleagues in the PAL service and heard about the work that they're doing, and we continue the work to raise the profile of that service to supporting our patients and relatives and families and members of the public. The workforce, we've got a workforce report, so I won't steal too much thunder, but I do need to obviously formally say that Bill Nuttall, this is your last meeting. It is. We'll be leaving HCS on the 20th of May. Bill, do you wanted to, you've asked whether just to say something.
Yeah. Thank you. Can everybody hear me at the back? Okay. So I wanted to make a personal statement to the effect that I recognise that there had been speculation about my departure from Health and Community Services, and I wanted to actually confirm this is down to family and private health matters regarding a member of my family who needs my support back in the UK. It's not to do with any work-related issues, I can assure you, quite contrary. It's been an absolute pleasure and a joy serving the people of Jersey. It's been an absolute privilege working with Chris and the executive and Caroline with the board. And this was a very tough call, but as a husband, which gives you an insight as to the personal matter, it was a no-brainer. But what I'm trying to do is to ensure over the coming weeks, before I do depart, that there is a very thorough handover list of topics so that my replacement, who will start on the 1st of June, has got a list of things, a clear statement as to where I'm at. and also an idea of what still needs to be done. And I'm sure this person will take HR workforce to a different level and actually build on what I've tried to establish during these first 4 or 5 months.
Thank you, Bill. Thank you. Okay. You'll talk about the talent acquisition system in your report, and also, importantly, reviewing the arrangements to facilitate voluntary services in HCS, which of course is a feature of many hospitals in the National Health Service, and many are blessed with a whole range of volunteers to support staff and patients. So looking forward to that. Finance, again, we have a finance report, but you'll see the highlights in my report. I won't go through them because I know Obi will, so I shall leave that. Avoidable harm, quality and safety indicators. We have seen a rise in deep tissue injury, and we're currently investigating what might be the cause of that. And Jessie, will you be able to pick that up as part of your quality? All doing that, yeah.
Yes, we are in the process of investigating all of those deep tissue injuries, so we'd be better to come back next month with the results of that rather than speculate as to what was the
Well,
cause.
perhaps you could tell us, for those of us who are not fully aware, what on earth a deep tissue issue is.
Deep tissue,
Tissue issue.
deep tissue injury is a breakdown in the skin where there has been trauma, so it may be that the patient has been sitting in the same position or lying in a difficult position, or it may be a piece of equipment that's caused it. So we're looking at the TED stockings that patients wear, ensuring that they're removed and that the skin's checked regularly as it should be. So it's that breakdown of the skin, and that's why the nutrition is so important, as well as the daily checks on the skin. And that's what we're looking at, what was the cause of the deep tissue injuries that have occurred in the past month.
I think most people might know that there's pressure.
Pressure trauma,
Yeah.
pressure injuries.
Thank you, yeah, I thought it was a pressure.
Yes, sorry.
Yeah, so sorry, whilst we're on this point, because I've got it down in my questions to ask anyway. So I was wondering, it says we've seen a rise from what to what. I think that would be useful to know.
So we aim not to have any of our deep tissue injuries, because the pressure injuries are categorised. So we don't want to have any pressure injuries acquired in care, but deep tissue is the most serious, and we aim not to have any. So we've seen 7, and we need to look at the root cause of those 7. Why have we suddenly gone from nothing to 7 for those injuries?
And final question, are they all on one ward, or are they across all the wards in an even distribution?
No, they're not. They're not in one ward. They're across several wards. But there may be a common theme that we need to look at and investigate.
Thank you. Thank you.
Thanks, Jessie. Okay. Peer reviews, obviously we have the Jersey Care Commission with us today. We've recently reviewed our nursing assurance framework and decided to move away from what's known as the JNAS, which is a nursing-led assurance framework, to a peer review programme. Jessie, are you going to pick that up as well in your report? If you want to, should we cover that now?
Yeah, I've got questions on that too.
Okay. So for the past 5 years we have been doing the JNAS assessments, which was completely nurse-led and looked at each ward and resulted in often a lengthy action plan that then would lose traction over time. The peer reviews is a much more robust system that gives us quick information that we can look at the recommendations that are short, medium and long term. We have all but completed just 3 areas to do now of our first peer review assessment, and the teams have been clinical and non-clinical staff. So that's a bit of a change from the JNAS system where we were concentrating just on nurses. The plan, once we've got our process up and running, is actually to make it multidisciplinary, so to have a doctor, a nurse, a non-clinical person and an AHP on each team of 4, and they go in and they spend an hour and a half to 2 hours in the area with set questions and set criteria that they're looking at. They look and they feel of the department, how patients perceive their care is being delivered. So a lot of discussions with patients and a lot of discussions with staff about what is happening at that point in time on the board. And from that is recommendations. Some of them are immediate actions which we have undertaken, and some will be in the short and the medium term, and those will be auditable.
So, I mean, Cathy, I will bring you in if you want to say anything about this as well. So my question, I've got two questions and a point actually, if I might. So, I personally think peer reviews are excellent practice. One question would be, would it be an idea to involve a lay person in the peer reviews as well, not just a non-clinical person, but a lay person from outside the hospital? So I think my view is that would be really best practice. And then it's more a question really for you, Chris, than for Jessie. I think peer reviews are really good practice, and if you're a peer reviewer, you learn as much as you give, to be honest, so it helps in wherever that person is working as well. But why we're just doing it in nursing, should we not be doing it across all our services? So that's a further question. And then the final point I got to make was, once you've done all the wards, I think it would be useful for the board to see a summary of the issues arising from. But I'll leave it at that. Just pass over to Cathy, and if you come back on the other issue.
Yeah.
Thank you, Chairman. I think very much the introduction of the lay members of the public is routine, and in fact, as we actually started, Jessie started what we called a proof of concept. I think for many of us that come from mainland UK, we're used to the peer review process, but actually ensuring it fitted with our profile or ward layouts was important. But as part of the initial peer review, we actually did have lay members. So that was our proof of concept, but very much going forward. And I know Jessie's already spoken to our assistant ministers looking at how we can use engagements, but using our expert patients. I think the issue with regarding to feedback, as Jessie identified, any immediate concerns were raised at that time. But not only were they raised at that time with the clinical area, when you came back to that lunchtime and had that feedback, it's what we all learned. If on Cathy Stone ward there was this challenge, and we made sure it's not on everybody's ward. You know, just as we found it today, let's share in the here and there. A report went back, and where Jessie is at the moment, collating these reports to actually have what those things are. Each report will have an area and will have their own identified challenges. But overall, there will be a theme. We look at the people survey, and how do we as an organisation take those forward? And picking up it's not nursing, I think, whilst it's been led very much by the interim chief nurse, when you go onto a clinical area, you're not focusing on the nursing staff. I mean, Professor Mackenzie went into ED, I think, much to the dismay of most of the clinical staff, and he had a very, very challenging peer review, but it was a very professionally challenging peer review. So when we undertake a peer review, it's the clinical area, it's not just looking at the nurse, it's job nurse. And very much what we do want to see for the future is that real multi-professional approach. But I'd really like to commend the chief nurse to, getting a peer review process up where we've now managed, with the exception of 3 areas, one of which maternity, and we had a very traumatic inquest at that time, so that wasn't fair. We've been able to take the whole organisation, and that is a real credit.
Just to answer the question is yes, peer review is important, and indeed the reviews of specialties that we've commissioned from the various royal colleges, of course, is exactly that, and these are peer reviews of specialties in Jersey. We've also, I think I mentioned it a bit later on, we're getting it right first time reviews. The end of my report again is a peer review from around our services. So it's a central part of ensuring that we are up to date, that our services are safe and effective. And we know that from the reviews, and we've seen here now since the board came into place, the maternity improvement plan, that came from a peer review of our maternity services. So it's absolutely essential that we continue with that.
Sorry, Chairman, I forgot to say, the peer reviews will happen on a monthly basis, whereas the previous accreditation scheme was on an annual basis.
That's much better.
So every month, and more in an unannounced format. When we undertook the proof of concept, we let staff know we were coming, but very much, This month we know we have a challenge with hydration, so we're going to target 5 areas this month and we'll look specifically at hydration. So the challenges will be led by our population.
Great. Thank you for that. Carry on, Chris.
Okay, thank you. Mental health and social care. The position in mental health and social care remains, as it says in this report, stable. There's been no significant variance in either way. I do want to highlight, because I've again received excellent feedback from a number of staff that were involved in the staff engagement event that was held. I think it was, yes, it says in my report, 160 staff across mental health who were involved in that, and I think that was a very successful event. The other thing really to highlight, which I'm pleased about, is the mental health services are in the process of recruiting now some what we call a team of peer support workers, people with lived experiences of mental health who will work as part of the MDT going forward. So that is a hugely beneficial move. It's what we might see in mental health services elsewhere, and I imagine, Tony, you're pleased with that as well. So that is something that we will be moving forward with. We've got a waiting list report, so I can leave Claire to deal with that. The same with emergency services. There's just summaries there in my report. Regulation, I've just seen Becky arrive, I think. It's probably just so we're clear, and I mentioned in my report, because it sort of confused me initially, that there are actually 2 consultations. One is from the Minister of the Environment, and that is a consultation on the legislation that will be required for the Jersey Care Commission to regulate hospitals and ambulance services. And the second, which we will hear about today from Becky, is the consultation on the single assessment framework standards for hospitals, mental health and ambulance services, which is a separate consultation. Obviously, HCS will be responding to both, but I just tried to, I got a little bit confused that there was the 2, so just for the board's benefit, that's the position. And I mentioned the Getting It Right First Time review. The reviewers, led by Professor Briggs, who is a orthopaedic surgeon with a national reputation, came this week, and the findings of that review will be obviously fed back to our clinical teams, the senior leadership team, and then ultimately carried to the board. So that's the end of my report.
Thanks for that, Chris. Well, we've asked quite a few questions already. Has anybody got any questions for Chris over and above? Tony?
Sorry, I hope it's worth the wait. Yeah, just want, Chris, as always, thank you for the view from the bridge. I think it's very important to get that overview. I think it's important in celebrating the Vicar survey results, which were very encouraging, and especially we talked last time about that 99% kindness experience that people have from the way the staff operate. Very encouraging. I think it's very important that we're not seen by staff as patting ourselves on the back for those results, really, but that we're focusing on how we can improve staff experiences and customer experiences even more.
I think that was basically a contribution, no need to answer that. I did have a comment to make on mental health and the prescribing of cannabis for people with no serious mental illness. I think it says the issue is now being taken up by Andy Weir as Director of Mental Health and Social Care. I think it would be really helpful if that report, a report on that, went into the Quality Committee, just to be clear what the patient safety issues are in relation to that, and that goes to the Quality Committee. Is that
yes,
okay?
Yeah.
Patrick, that's you, yeah, okay.
Yeah.
Lovely. Thank you. And then waiting list, because Becky is here, I'll leave my question on the waiting list to we come on to it later, Karen. But yeah. Okay, on that basis, I think thank you very much for Chris, and we can welcome Becky Sherrington. I hope I got your family name right there. Yeah, you're very welcome, Becky. Please sit down. You've sent us some slides, for which thank you very much. I'm sure we've all been able to have a look at those. I think it would be also helpful if you're able, when you're doing your presentation, to talk about the standards against which the services will be judged. So I think when I looked at your more detailed documentation, there was very clear areas of standards which you will be judging against. Thank you.
Well, thank you for inviting me. Is that working?
Becky, do you want to, just so I can see the slides, if you sit here, is that going to be easier? And I'll walk down. I'll hobble down there.
Is it possible to bring my slides? Yes. Sorry to be called. So for an introduction, thank you for inviting me. I'm the Chief Inspector of Jersey Care Commission, and it's great to actually see the public here as well, because this is a public consultation. So I, as I said, am the Chief Inspector of Jersey Care Commission. I'm a nurse by background, so I have a very operational background. For the last 2 years, I've been the regulator of health and social care. The Jersey Care Commission, for those that don't know, so I presume you all know, but for those that don't, we regulate health and social care on the island. We take around 107 inspections a year. That includes healthcare, day centres, care homes, home care providers, and recently we've taken on social care. So we've regulated CAMS, children's social work, we're about to do fostering and adoption. And all of our reports are published. So one of our key principles is that we publish our reports. We're open and transparent. So all of our publications are published on our website, and those go out across social media. I'm the executive lead of the Care Commission, so I run the team. I've got a team of regulation officers, and I am governed by a board. So the Care Commission have a board. They are predominantly off island. We have one person who's on island who's got a lot of experience through her daughter who's got severe learning disabilities. So she's experienced a lot of care on the island. And the chair of the Jersey Care Commission is based in Northern Ireland and used to be the Chief Inspector of the Northern Ireland Inspectorate. So really experienced team of commissioners. The purpose of the Jersey Care Commission isn't to catch anybody out. So very often regulators are seen as the red tape or the people that gotcha. And as a regulator, that is really, really not our role. Our role is to improve health and social care. And the evidence says is that if you beat people up with a stick, you will never improve health and social care. So our role is to support and hold a mirror up to organisations so that they have got the opportunity to see what is working really well and also what isn't going so well. So examples for children's social care, we've gone in and we haven't said this is dreadful. We've actually said that you're doing this really well, you've got it really right and you're doing really well on this, but we can see that there's some areas of improvement and you need to do that. Regulation needs to be on island as well, so some of the calls recently have been, why don't you just bring the CQC in? But actually, as a regulator, you need to have the backing of the law behind you. So as I've said, we don't beat anybody up with a stick. However, we do have the law behind us. So if we need to, we can provide that stick and we can improve health and social care by the backing of the law. So the regulation of care law, as I said, is being amended at the moment, and that is being out for public consultation. And the proposal is that the Jersey Care Commission regulate and inspect the hospital. However, as a small regulator, it is acknowledged we can't do this on our own. So we are working with other regulators. So the CQC have signed a contract to work with us, and there we're providing expertise to support us. So the blend of the team is, I think, equally, if we go in and inspect the hospital on our own, the challenge that will be given to us is you're not independent. So we've got a blended model. We've got regulation officers that know the island, and they are very experienced in health and social care as well as inspecting. And we'll also have experts from the UK who again equally have expertise in regulation and inspection, who will be supporting the team. So we're covering both bases. We're going to have people that know the island and know the context and have experience of the regulation of care law, and we'll also have inspectors from the UK as well. I've probably covered all my slides.
Oh, sorry.
Give me a microphone and I'll go wild. So, as I said, we've inspected children's social care, and those standards are on the website. And when I came into post, people said, "Oh, you'll never be able to do it." So tell me that and I'll do it. So it's probably the best thing that somebody ever said. And we've done it. And those social care inspections have been really valuable to the Chief Officer in Children's Social Care. It's given him assurance about what's working well, and as I said, it's given him an opportunity to find out where his risks are and what he needs to do to improve the care for children. And we've also, for the first time, had a report that's transparent and is based on fact. Because on a small island, people have views, but very often it may not be based on the most up-to-date facts. So those facts are now published and they're out there in the Children's Social Care Inspection. So I'd encourage you to have a look at those, particularly the CAMS one as well. So those are now out there, and we've almost finished the inspections for children's social care. Next slide. So as I said, there's 2 public consultations, and the Chief Officer's mentioned that. There's 2 public consultations going out at the moment. The first is being led by the government. So the government of Jersey are running a consultation on the amendment to the regulation of care law, which will include the hospital, mental health services carried out by the government of Jersey, and also ambulance services. It is also proposed that it won't be just the Government of Jersey ambulance service, it will also include those private ambulance services as well, so Normandy Rescue, for example, and St John's. So that's the proposal. That will be debated by ministers this year, so that's the process it goes through. It's been, the law drafters have written it, it's now out for public consultation, and then ministers will debate it this year. So whilst we're anticipating that this will go ahead, we're getting prepared as a commission. So we've started to write a set of standards. So standards are explicit, and they tell the service what they should be doing to provide a level of care. So that sets out the benchmark. This is what, as a provider, we will do. It's also really important that islanders know what they should be expected to be provided with. So the standards are written, so it says, as a provider, we will. It also underneath there says, as an islander, or I will, be provided with care that is safe. So it's written in 2 forms, what the provider will be doing, but as an islander, what you should be expecting to receive. So we've done that. It's quite a difficult task writing detailed standards for both the provider and an islander, but we hope we've achieved that, but we might have got it wrong. So we're encouraging all islanders to respond to those standards. And when we published the standards for children's social care, we got comments and feedback, and that was really useful to us, and we did amend those standards. So I'm encouraging all islanders to have a read of them. I know it's quite dry. I would encourage you to do it because it's really important. And I'd particularly encourage HCS to respond on those standards. And I've provided you with all the communication collateral for all of your staff, and we'd encourage all staff to have a look at them and respond. And I'm also very open to come to any meetings and explain to staff what this means. Because at the moment it's a really important piece of work, and it's important we get it right, because once we publish them, that's it for a few years before we amend them. So next slide. As I said, we're working with the CQC. So the CQC, the UK's, or the English regulator, have provided with some advice on their standards. You could ask why we aren't working with another regulator. Why aren't we going to the Welsh or the Scottish or the Northern Ireland regulator? But we've had a look. We've done a big piece of research of all the different standards across the world. And the CQCs have recently updated theirs. So Some of the other regulators haven't updated theirs post-COVID. So the CQC have done a big exercise in updating theirs recently, so theirs are the most up to date. So we're using those as a benchmark, and we've updated them to make sure they're Jersey-fied. So there's things in there that are really relevant to Jersey. So for example, we have air transport to get people off the island in a medical situation. So there's nuances that we've made sure that they are really applicable to Jersey, but at the same time they stand up to international best practice. Talked about that a lot. So the consultation is open for 6 weeks, so it's open until the end of May. So I would really encourage you to respond. We've got a form that you can fill on online. We've also got 2 consultation events, one at the library and also one at St Helier Parish Hall in the evening. So we've got 2 events that translators will be available to support those that English isn't their first language. Again, equally, we're also working with Enable Jersey, one of the groups on the island that supports people with disabilities, to make sure that we work with Enable Jersey. And we're also working with the Children's Commissioner to make sure that they're right for children as well, because they'll obviously cover areas such as Robin Ward, the emergency department, etc. So it's important we get it right for all of our islanders. So I was asked what is the standards like. So I'm not going to go in a huge amount of detail in this meeting. They are available online to be looked at. But we've split it into 5 areas. So as an islander, if I walk into the emergency department, what should I expect? Well, I'd expect it to be safe. I'd expect it to be responsive. I'd expect it to be caring. I'd expect it to be effective. There's 5 different areas of those standards that those cover. So those are the key elements. Is it safe? Is it effective? Is it caring? Etc. Underneath that, there are 35 standards that say we will provide, or as an islander, I expect, for example, the environment to be clean. I expect to know what the complaints procedure is and what I should do if I've got a concern. I should be told what the visiting hours are. All of those sorts of things. Underneath that, it then says what the standard or the regulation is. So it links again, so as I said earlier, we've got this regulation of care law. So that standard relates to this area of the law. So if the worst case scenario happens, and we have to fall back on the law, we can clearly say to, for example, Patrick or the Chris Brown, Chief Officer, you are clearly, repeatedly in breach of this regulation. You need to do something about it. And it clearly explains and relates to the law, so they know that they are accountable to that law. It then says there's a universal requirement for all care providers, so what those different requirements are. And then underneath that, we're then going to write some really specific areas. So for example, if I walk into maternity, I would expect certain things to be in place, so the scanners to be in place, etc., etc. If I walk into an emergency mental health unit, I would expect, for example, no ligature points, etc. So there are certain things, certain details for certain areas that we'll have in place, or a dialysis unit, for example. But we're not going to publish those for public consultation because they're very technical, but we will be publishing them once they're ready. But we're not going to go out for public consultation for that, because I think it's quite a nuanced area. So we're working with the people, the experts within the services and the CQC to write those. And we're beginning to publish those later on in the year. Next slide. Cover that. So as I said, what do we need to do? Next slide. Please read the standards. Let us know, are they accessible? Are they easy to read? Do you understand them? Is there anything missing for you? What does it mean to you as either a care provider or an islander? And they're all available on our website. That's it. Happy to take questions.
Well, thank you very much, Becky. I don't think that the board is today going to give you a response to the consultation, because that needs some careful consideration, and that will be done formally. Obviously, once the response is done, my expectation is that we will publish our response to the consultation along with sending it to you. But my first comment is, so I've got here on my iPad your 35 standards that against which you will be inspecting. I personally thought they were very good, very clear, and I was clear what it means for HCS. I personally thought I was less clear about what this means to people and some of the issues about what this means to people and whether people are really in a position to know some of the things that they're expected to know. But I think that is probably something that will develop as you go forward. But I mean, so for example, I could go back to one which I read, which was the implications for people, and it's about transfer. And so if somebody has, I think the issue for me is, so if somebody is getting out of hospital care, and you're looking at HCS and the hospital more broadly, where the overlap is between their out of hospital care and whether that comes under a different type of regulation or whether it comes under the HCS regulation. I wasn't quite clear about that issue, and I didn't know whether a member of the public would know that either. So I don't know if you're able to, it might be just me being a bit dim.
No, I think that's a really good question. So, as an island, regulation is very undeveloped. In the UK, GPs, pharmacists, the whole dentist, everybody is regulated. On an island, we're on a phased approach to that. So it is recognised by ministers that we can't do it all in one go. So the regulation of care law is being developed in different phases. So the first phase is being, as I said, home care services and children's social care because of the Jersey Care Commission care inquiry. Now it is going to be the hospital, ambulance and mental health. However, certain services are out of scope. So for example, GPs aren't regulated at the moment. But having said that, there are services, core services that are already. So family nursing, home care, their district nursing, their overnight service, their rapid response services are regulated, and children's social care services are regulated. So with this policy amendment, lots of the island will now be regulated and inspected. If you think that these could be further embedded in terms of the interagency working, then please let us know. As I said, this is a consultation that we really want feedback. So if you think they can be strengthened, then we'd really take that seriously and we'd welcome that.
Well, we definitely will go through it all in detail and then make a response which we will make public. So thank you for that explanation. Chris?
Yeah, so this one work it does. Just a couple of points. Obviously, I've been used to being regulated in my previous lives, and this is much welcomed as a move to Jersey. And just a bit of feedback. Last week, I spent some time with staff at the Hollies Day Centre and Sandybrook Day Centre, both social care facilities, both of which are currently regulated by the Jersey Care Commission, and I spoke to staff about that, and actually they found this to be really helpful and regulation to be really helpful. It gives them a focus, they know they're accountable, and they've always felt that it's a focus for improvement. So I wasn't receiving any sort of negative feedback about being regulated. It was definitely seen as helpful, not easy and say accountable, but certainly the staff I met had always found the inspections from the JCC, particularly in those two day centres I visited, to be helpful as regards to a focus to improvement. Your point that you raised.
Well, that's a relief. We also, it is really important that we get it right. And as a regulation team, we are there to make sure that things are safe, but also we encourage improvements. As I said previously, people think that regulation is there to catch people out or is overburdensome, but we need to prove that it actually improves health and social care outcomes. So every year we do a survey of everybody who's inspected, so they get at the end of the inspection a survey. And then once a year we go back to them and say, what are your reflections of the year? And we're going to be publishing next week annual feedback. So 55% of providers came back with a response, and that was overwhelmingly positive. So we are, I think, getting it right. I also think it's really important that regulation is in place. It's a way of being transparent. It's a way of demystifying and being not based on anecdotes or people's discussions. It's about based on fact. People start to get the facts about what services are like. As you said, sometimes it's uncomfortable for services. We've had recent experiences where care isn't safe, and that has been very uncomfortable to deliver that message and publish those messages. But at the same time, our role is to make sure that care is safe, and we can say that people in those care settings are being looked after in the best possible way.
Yeah.
Like Chris, I've lived and worked in a regulated environment for many years in the UK, and from a workforce HR perspective, I've found that the reports from the CQC to be very helpful, because they inform continuous and service improvement, they inform strategy, they help to convince people who know you down the street that the hospital that you're working in must be safe if you get the right rating. But it also helps with that improvement. It's important to have a benchmark. And what I was going to suggest to the audience or colleagues is to have a look at those ratings by Googling some of the NHS trusts. Not to be afraid of what the reports actually say, but they're invaluable reading. And some of those reports can be hard-hitting for management, but without them, the informed decision-making on how to have that continuous service improvement can be found wanting at times. So I've always found them a great benefit.
Not sure if everyone's being so.
Yeah, Kathy. Thank you. Like Bill and Chris, not only have I been regulated, but I'm also a regulator, so I'm sort of gamekeeper turned poacher. But really, I'd welcome this for Jersey in many ways, and it's not because it's regulation, because it's the right thing to do. And we must have regulation, because I think that's key. But actually, we do it because it's the right way to do it. We do it, it's the right thing to do, and we do it because we can build and develop and move forward, which I think this is a great beginning. And as Bill and Chris has actually said, you read the reports, some of them aren't easy to read. But, you know, that's that beginning to say, yes, we are going to get it better. And, you know, getting better never ends, and I think that's what's really important. So I think, and the single assessment framework, exactly what you've actually said, Becky, I really commend everybody from the public to read them. If they make sense to you, that's what we need them to be. We need to know that the Jersey Care Commission is there, flying the flag to make sure each and every one of us get that care that we deserve. And I really commend that.
So there's 2 points. The rating is it's a hot topic at the moment. We aren't going to be rating the hospital. So as a commission, we've debated whether to rate things. Very often the care providers that are doing really well want to be rated, for obvious reasons. But as a small island regulator, we've decided that we won't be rating the hospital in the current way that we don't rate other care providers. Because I actually think that it's a blunt instrument. You might be doing brilliant in one area, but then maybe failing miserably in another area. So how do you then summarise all of that into one single word? And I think that people are far cleverer than we think. That actually providing a report that says, this is what the service is doing really well at, but actually this is what needs to improve, is actually okay. And that's working at the moment. So as a care regulator, we won't be providing a judgment, but we will be providing with a report that says, this is what needs to improve, and this is not what working well. So we won't be providing you with a single judgment, you're outstanding or you're failing. Because actually I think it's a little bit more complex than that. And it's a debate that's occurring with all the regulators at the moment internationally on what's the best approach. But for a small island and the Commission, we've debated it, and the Commission have said, let's stick to our reports
Just on that point, once again, I personally welcome the fact you're not going to give a single word judgment. Just a personal example, I had a child who went to an outstanding state school. In my view, it was absolutely terrible, quite frankly. So this single word, and it probably was intelligent, this single word is not helpful, because there will be really good and really bad parts of every large, complex organisation. So personally, I very much welcome that you're not doing a single judgment, and we've seen the tragic consequences of that in the UK as well. So I think well done to Jersey for being more sophisticated than that. I'm going to come back on the point of view.
It was just about the timing of the inspection, because I think the hot topic is when will it be then? So there is a process that needs to go through. So the ministers need to agree this. So we are waiting for that ministerial debate. So the ministers need to agree the law, and that will be debated, and that's going to be lodged later on this year. So once that's lodged and the ministers debated, if it's then decided by the ministers that this law amendment takes place, that will probably happen by the end of this year. So the law will then come into effect in January 2025. And then as a provider, you then have 6 months to register. So you'll probably take those 6 months to register. And then we then will start to inspect you at the end of those 6 months. So at the end of June, you then should be well in a position to start being inspected. Second question, the question is probably end of 2025, your first inspection will occur. The question will be, will it take place? Will it be announced, unannounced? It is likely that it will probably be announced. Will it be full focused, so we could look at one single area, or we could look at all the different areas? So again, we'll decide that. So we haven't decided whether it's going to be announced or unannounced, and we haven't decided what the focus of that inspection will be.
Bobby.
You can actually write my finance better. There's no argument you have to make a judgment. It's pretty clear. Can I ask you, whilst a single rating, I completely understand, it's always more complex than that, health especially. But across the different domains, would you be giving a rating across different domains, which would then balance the overall view?
I think it's more the inspection methodology will be decided upon. So I probably can't give you a full answer on that, but I think it's more likely that you'll get a report that gives you the judgments as a written judgment as opposed to a specific score. But I'll come back to you on the inspection methodology later on.
Tony?
Yeah, thank you very much. I should probably know this, Becky, really, but to what as you know, in the UK, the Care Quality Commission is now conducted. The Care Quality Commission is now resumed looking at local authorities, how well they assess and manage people's care needs, in line with what over there is the Care 2014 Care Act. So, as well as the quality of experiences, I'm interested in knowing how here in Jersey you'll be assessing, if you are, the way in which we assess and manage care needs as an organisation.
Across the system or in your
Well, I'm looking in England, of course, it's separate, local authorities from the NHS side, really. But here it isn't. We benefit from an integrated structure, which should give us enormous opportunities to see across the piece, really. But I'm looking as kind of the out-of-hospital NED lead. I'm looking specifically at how we look at people's care and support needs, which don't necessarily involve hospitalisation.
So, it's going to sound a terribly boring answer, but my powers are dictated by the regulation of care law.
Sure.
So the regulation of care law says what we can inspect and what we can't inspect, and that in itself is debated and decided by the ministers and the policy team. So at the moment, my specific task is inspect the hospital, inspect the ambulance, and inspect the. So the system itself isn't in the same way as it is in the UK. Having said that, we're also very new to regulation, and in the UK, the CQC have been doing this for many years, and are looking at different ways of regulating, and they started off by looking at single units. So I think we may get to that point, and I think that's a good way to get to. It's a claim that children's social care are talking about as well, that you're inspecting us, but actually we're part of a big system, we're part of criminal justice, we're part of all different education. Why aren't you looking at the whole system? Again, I can't do that because of regulation of care law. So it's yeah.
Great. Okay. Well, I think at that point, you know, a really big thank you, Becky, for coming today. As I say, we definitely will be making a response, and we will publish that response as well. And then it's next year, isn't it, when you are due to start the process? If ministers agree. So on that basis, subject to ministers' approval, we look forward to seeing you, and rest assured we will be preparing. Yeah. Thank you very much indeed for your time. And please feel free to go. Okay. Thank you. Let's move on then. So the next item on our agenda is the Quality and Performance Report. And Claire, this is you, isn't it? I mean, Claire, I think because we get this on a monthly basis, just tell us about anything in your introduction, anything that's specifically different than last time.
Thank you, Chair. With that suggestion, I'm happy to respond. Colleagues will note a slight change in our rate of progress around reducing people waiting longer than 52 weeks for a first outpatient appointment. This happened due to a few reasons. We knew that in some specialties, particularly there were a cohort of patients that were in the 180 to 300 day cohort that were going to sort of bring pressure. And also, while we're waiting for particularly some of the waiting list recovery programmes to hit, it's actually, obviously in terms of numbers, quite a small change. However, as we go into April, I'm confident that with the work that I can see taking place in month, we'll be turning the tide again on that, and that's particularly in relation to dermatology and clinical genetics as a couple of specialties. We did have actually quite a significant, so in the last 2 months, so in March we actually had 500 more referrals in month compared to the month of January. So whilst those are not these patients, because obviously these are the patients that have been waiting longer, what it does impact is how we use our capacity in month, because with those increased referrals comes patients who are being triaged as urgent or soon, and obviously we have to divert some of that resource away from dealing with the longer patients appropriately, obviously due to clinical risk. But as I say, wanted to pick that out because not necessarily the rate of improvement that I wanted to see, but a culmination of issues that I think I did pick up in my report last month. Really great to see all of the work that we were doing with our inpatient capacity actually starting to impact performance and reducing the numbers of those people waiting for inpatient care. And obviously, as we discussed at board before, that's also been compounded by our work that we've done to reduce our outpatient lists. But obviously we know that then a lot of those patients then need to follow up with inpatient care. So great to see that reducing. A lot of the other elective performance metrics continue to improve with the work that we're doing around some of our diagnostic waiting lists. New to follow up, we know that we've got a few specialty outliers in there. We're aware of those and we're working through those with our clinical productivity work streams. And again, at DNA, lots of work going on in relation to that, and really great to see our the cancellations on the day for non-medical reasons continuing to reduce, and utilisation continues to improve. And then just in terms of emergency care, although we did see, treat and discharge more people within 4 hours, which was fantastic, we have seen patients waiting a little bit longer within the department. Just reminding the board and the public, obviously patients in the emergency department more than 12 hours, that number does contain people that will be discharged, so that's when we're waiting for admission avoidance, social care, rapid response. So it's the right thing for the patient. Obviously they're safe. We wish that they weren't in the department as long, but obviously that's why we're making sure that they get the right care and not being admitted when they don't need to. And also we did have some infection control issues around norovirus that we saw in the hospital, and obviously it was present in the community, which obviously made some flow into the hospital waiting for sirens, etc., slightly compounded. But we can see that we're managing our capacity in a safer way, and our non-clinical transfers overnight continue to reduce, which is obviously great for patient experience. So those are the highlights from my section of the QPR, Carolyn. Thank you.
Thanks very much for that. Does anybody have... Oh, Patrick.
I think Jesse's highlighted some of the quality and safety, but just within the maternity, it was just to provide some feedback. We've talked about massive obstetric hemorrhage in the past. Just to reassure the board that we're seeing a reduction in the trend in terms of numbers. We have recently received back the schematic review report on a number of massive obstetric hemorrhages, and that's been helpful. It's made a lot of recommendations, but the vast majority of those recommendations we've already implemented, so it's just to provide that assurance to the board. But we'll probably bring that in the maternity report next month once we've had a proper look at it.
Brilliant, thank you for that, Patrick. So, any comments from any colleagues over and above? No, well, I do have a couple. So you mention in the report that there are plans to increase the capacity within the service, which is ongoing, with a long-term strategy proposal in its infancy. I don't really understand what that is.
So that's in relation to, that's updating the board in terms of dermatology. So I think we mentioned a couple of months ago that we were, I think the word was a review. What that really is a service plan. So particularly in relation to the long waiters, we know a lot of those are the patients where we had that real issue with dermatology capacity in the summer, and obviously we're seeing that impact of those long waiters now. So it's just really understanding how we're going to maintain and develop and improve the overall service. It's a very challenged specialty to recruit into internationally. We know that there's more that we could be doing within primary care, so it's that whole review. But lots of exciting work, but we're pretty much fully recruited. We're actually recruited some staff in both medical and nursing posts, and I can see the overall dermatology waiting list is reducing.
Thank you for that. And I was going to say very good news on diagnostics as well. But my final comment was about the increase of 500 referrals. Do we know what? I mean, that's in 1 month.
Yes.
So do we know what has actually caused the 500 increase?
So we are reviewing that. We can see that there are some specialties. Some of that is natural ebb and flow. We do see that over a 12-month period. A lot of those are physiotherapy referrals, which is not uncommon when we benchmark against other organisations. So we're trying to review and understand so that we know how to plan. Obviously, for the future, if there's anything that we can do to reduce those referrals, mitigate them in a different way. Is it about GPs having access for help and advice, etc., that we know could then prevent referrals, but then also to allow us to recover and change services going forward. So a lot of physio, and then a few others across, cohort of specialties going.
And is that continued? Because this obviously, is a point of time, isn't it?
Yeah.
When the report is done. Has that continued into the next month as well, that increase?
I can see that we've had about 3,500 referrals in the last 30 days. So that would show that actually in April they're reducing slightly.
Sorry to keep going, I'm being a bit
That's all right.
nitpicky. Back to normal or still an increase on what it was?
So back to previous months,
Okay.
so lower than the increase of 500, yes.
So that is very bizarre then to have 1 month with 500. So I do think that really does need some proper investigation as to what is happening there within the wider system.
Absolutely, we're doing that to understand.
I think it's something we can pick up something we can pick up when we meet with the primary care. We have the monthly primary care board meetings. We can pick that up and see if our GP colleagues have any sense of why that might have been the case.
Absolutely, yeah. We have seen we have seen the same amount of referrals in a month as high as that before, but again it has then resolved itself. Sometimes we get batches, particularly from community dental, when we know that there's a encouragement across the education centre to register children. So it can, we do regularly see that across the year.
Okay, well, I mean, that is about the joining up of the whole system,
Yes,
isn't
right,
it, really,
yes,
which does
absolutely.
need to be, because if some part of the system, whatever that is going to encourage and do a public health campaign,
Yes.
then actually you need to be preparing for
Yes.
that once the impact is felt. So I think that is a really important issue. So it won't just be GPs, it will be
Yes.
the wider health system.
Absolutely.
won't it?
Yes.
So,
Public health. Yes.
yeah. Well, let's keep a really close eye on that as
Yeah,
we
thank
go
you.
forward this year. Yeah.
Great,
Okay.
Thank you.
All right. And on that basis, are we okay to move on from that item? Yeah. Great. So we then move on to the workforce report. Bill, over to you. And, you know, before you start, just to say all the very best for the future.
Thank you. The workforce report is a standard report. It's been reported on before by myself and my predecessor. For those who are not familiar with it, it's split into 4 main sections: workforce metrics, workforce data, recruitment activity, and a range of topics. So what I will aim to do, Chair, if this is okay, is to pick out any key changes or things which are different from before, if that's okay. In terms of the metrics, the vacancy rate 17% remains as in the quarter from January to March. The turnover rate is remaining the same, although there is showing some encouraging routes of reducing from 6.9 in February to 6.6. Voluntary turnover rate is averaging as if it's flatlining, so no real changes there. Leavers headcount has increased and the sickness rate has increased. And I'll come on to that later. The objectives, this is the appraisals and development objectives, have shown a marked increase from the beginning of the quarter to the end of March, where we're at now, an increase from 8% in January to 27.5%. But here's the rub. With regards to the workforce data, during the time that I've been here, we've never had stability in the reporting of what the funded establishment is. And also, we've never been able to pin down the true vacancy situation. I did report at a previous meeting that hopefully by March we would have had a truer picture with systems talking to one another. That has not happened for various reasons. So what we've done is we've actually gone native. We've now created, Obi's team and my team have now created what's called a vacancy tracker, which was actually going to pinpoint the truer picture on the number of vacancies that we've got, together with a better picture on the establishment. My view is that systems invariably can become clunky, they don't interact with each other, they can give you an inflated picture one month and it can change the other for all sorts of anomalies. So what we're trying to do is to bring credibility to what that vacancy picture is. And that helps with our recruitment campaign, of course, as well. With regards to sickness absence, the current AXA healthcare contract that we've got at the moment, which runs out in November of this year, there's a report, there's a review being undertaken, and that report is going to be concluded at the end of this month. And I would think that there's likely to be a change. What I would like to see is there's going to be a change, because I think that the reasons why we're having reports as to why people are off sick, which is cold, flu, gastrointestinal, are archaic. I think there are more varied reasons why people go sick these days, and I don't think that the report captures the true impact of working in a highly complex, high-octane kind of environment, where you've got things such as mental health, You've got other social related issues now that are impacting on well-being. There's other things that we need to take into account. With regards to connected performance and objectives setting, it's great that we're improving the performance of getting appraisals and objectives done. But the caveat to this is, where do we go with that? Where's the training budget? What do we do in order to make sure that the outcomes of appraisals can be realised with the individuals or the teams, and put the investment in to make sure we're improving as part of that continuous service improvement? It's fine if we say in 3 months' time we'll have 50%, 60% of our appraisal on objectives set. But again, how realistic they will be, where's the training, where's the backup to follow through, that people actually being developed as per their various disciplines within the health and community services. The workforce data, pages 6 and 7, show you the dilemma that we have various processes and systems talking to one another. If you look at page 7, I refer the audience and the board to page 7. If you look at the budget establishment as per Connect People, the government system, we would have a grand total of over 3,000 members of staff. If we look at another system, we have, according to finance and budgeting, under 3,000. So there are variations. Unless we get a handle and a control on our establishment and our vacancies, it's not helping us plan. It's not good enough, I don't think. And what I can tell you is that the work we've been doing with Obi's team and our team now, we've got a much better control, which will then bring me into recruitment activity. What I'm delighted to tell you is that since the beginning of 2024, 151 new staff have joined HCS. In terms of our vacancies, we have 284 vacancies where we've not yet processed. That's to say, we've not yet begun to advertise, prepare for interview and make the offer. What we can, however, say, we've got 138 vacancies that are going through the onboarding process, going through all the clearances, and once they've gone through that process, then we can actually start them on site, get them inducted, get them actually joining the teams. So I don't think the figures have been kind, I don't think the figures have been as accurate as what they could have been, and we're now getting to the bottom of it, which shows you more control and assurance. In addition to that, you heard from Chris saying that there's recently been a HCA open day. We've attracted 35 people who wanted to sign up. We've got tranches of people now being processed by recruitment. We've also got a contract with an external headhunting company to do cohort nursing recruitment from April, May, June up to July. They will hopefully supply CVs of 10 nurses at a time per month, so that if we are able to get, say, 5 to 7 people from that harvesting, we will continue then to plan for regular recruitment targeted campaigns throughout the year. I think what we might have been guilty of is the fact that we haven't systematically, that Jessie's been used to having that planned calendar of recruitment events. So the HC Open Day was the beginning of that new chapter, and now we're planning to have more targeted campaigns throughout the year, rather than leaving it until one person leaves, we bring somebody else in new through the door. I think we need to go just like the airplane carriers do. You overbook, but it's better to overbook rather than to underplan for people coming through the doors, and that will make a massive change. We're also hoping to recruit a chief allied health professional. That person will help us with strategic recruitment, and we'll be able to make improvement there as well. I've also mentioned the fact that we, from the previous meeting, we're going to try and reduce the time it takes to hire, the time it takes to actually provide the offer. We need to have closer discussions with people at Broad Street, people in corporate services. we feel that we're not in control of the administration side, the time it takes for letters to go out. We need to have more control of that. And in an ideal world, and this is my leaving wish, if you like, for the future, I would wish that HCS had its own recruitment administration team to support the great recruitment work that is actually being done. So we can mitigate any delays of getting offer letters out, getting the induction set up, getting the interviews coordinated. The more we're in control of things ourselves, the better it will be. I've also added...
Bill, if you could just summarise quite quickly the rest.
The one thing then, and apologies, I realise I'm being a bit generous with my time on my last occasion. But with regards to exit interviews, and this follows the remarks made by the person from Jersey Care Commission, we have studied a report that was commissioned last year. It was hard-hitting, but it needed to be, and we need to take note of things that we don't always want to hear, we don't want to see, we don't want to notice. But what we have done is shared this report with staff below executive director level. I'm also going to be working with HR from central government to improve the system. It's too online based. We've forgotten the basic manager to member of staff relationship of trying to retain people, but also finding out the reasons why people leave. But we will make improvements to that. And generally, with regards to the Connect system, talent acquisition, it's a government system, but we'll ensure that recruitment practice and standards are aligned with that to again improve our performance. I'm happy to take your questions. Sorry for going.
Thanks for that, Bill. Julie.
Firstly, can I just congratulate you, because I think this is a really informative report, particularly given the challenges you've set out around the data acquisition and the systems that underpin it. I wanted to just reflect, and again, I think we've actually talked about whole system quite a bit this morning, and it's a whole system comment, and it's in relation to the HCA recruitment programme, which I think is an excellent thing, and will be great if we get 35 people converting into new HCAs, but of course what we're doing is shuffling the deck chairs within the whole system, because a lot of these people will be coming from organisations within Jersey, and therefore we're shifting the problem of lack of staff to other places. And that can have a consequence for us in terms of, yes, the hospital may work better, but actually can't discharge people because you can't get them out into care homes or whatever, or into home care. And it's really just a plea to go back into the sense to think about doing a piece of work across the system with other providers to look at how we encourage people to go into healthcare assistant roles, and that's working with education in the schools with young people to make it an attractive career, and also perhaps to look at a joint initiative to look at how we might bring healthcare assistants into the island, because I think at the moment we're in danger of, just as I say, moving the deck chairs around.
I think you're right, and I think that having met with Mary Hodges from People and Corporate Services, there's going to be some work, I would believe, on the government website, My States. I think you're right, angling and promoting partnership working, greater anchoring, for want of a better phrase, health and community services more with the community. And as Chris alluded to, if we can develop and establish a policy for hospital and community volunteers, that brings that closer connection. I think the HCA Open Day event was a good event, and the more interrelationship we can do will also generate more interest and bring more local talent into the fold. Because if HCAs go through the training, conversion, whatever, then at least we've got a local talent pipeline, which means we don't always have to be 100% reliant on talent being imported into the island as well.
I think great point, Julie, anyway. Tony?
Yeah, a couple of things, thank you, Chair. Firstly, the sickness rate being double what it was at this point last year at 9%. And the report refers to the need to monitor what happens in the club. I mean, I'm sure we're doing this anyway, Bill, but we've got to be much more proactive than simply monitoring it. You know, we've really got to get underneath what's really happening. The reasons you say this, you know, we say the same, cold, flu, etc. So, well, why should twice as many people now be off sick because that's from a year ago. Well, just say that's the first thing. And then the second thing is about the appraisal, the objective setting and so on, which has leapt quite a bit from last month, but it still feels very low, notwithstanding the issue around the manual workers inclusion, which I understand really. So I think the board needs to be reassured as well about exactly what we're doing to accelerate that and quickly really.
Yeah, no, I agree.
You don't need to come back now, thanks, because the other comments. So, I agree. Tony's just read two of the points that I'd put down to him. So, on sickness, I think we need to have a report to the Workforce and Culture Committee, which is in May, on that, and then that's like day one, and day two, i.e. the board, the same report here. So the Workforce and Culture Committee will bring their detailed discussion into the board here. So if we could make sure that that happens on those. Likewise, on the 27.5%, we're 4 months into the year now. It really isn't good enough, and you accept that and acknowledge that in the report. I know Chris is concerned about it as well. But it's just a comment. Many reports, and it's not just this report, just say somebody is dealing with this, which is great. It's fantastic that somebody's dealing with it, but we don't know what that means. You know, so how are they dealing it? What is going to be different as a result? What is going to change, etc. So I think we would like some reassurance on that as well. So I think that again needs to come into the Workforce and Culture Committee to its next meeting, and again onto the board. I'm happy if that's in the workforce report, if necessary, covered in that way. But the board needs to have full reassurance about what is happening on those two areas. And then my final comment is, then I had another issue about the staff appraisal and manual workers, where you're basically saying you don't think manual workers will have an appraisal. I'd like to know, not now, but in the future, well, what is going to happen? It's not, to me, acceptable that manual workers are not, it's not that they're not treated in the same way, and it has to be an appropriate to their roles, but they can't just not be assessed and developed and supported in the same way as non-manual work.
I think, Karen, so just on that, yeah, I believe every member of staff deserves an appraisal and objective setting. I think this is an issue with the Government of Jersey policy, and that they had agreed with the trade unions in the past that manual workers, not just in HCS but across the whole government service, would not be subject to appraisal. So I think at the moment we're not able to implement it because of that union agreement, and what we're trying to understand is importantly about, because there are a lot of manual workers, you know, I mentioned some in Five Oaks, you know, CSSD, laundry, cleaners, porters. A significant cohort of the 2,000 staff are manual workers. So we need to understand what the percentage will be if we take those that through that trade union agreement out. I still think it will be too low. We're hearing from Jessie in a minute about nursing appraisal, and one of the real challenges we have is making sure that when appraisals happen, an objective set, they're put on to this Connect system. And you know, I know, for example, and it's the nuance, there were 2 directives where I had completed the appraisal a long time ago, appraisal and objective setting some months ago. I thought I'd signed it off on the Connect system, and I'm sure because of my inadequacies, and I obviously pressed the wrong button so they didn't appear, so I've had to correct that. So I think we have to understand what this is, and people do, I think, to be honest, struggle with the Connect system more widely. But I still think it's going to be too low, but we need to understand that, because if it's not on the Connect system, we've got this problem. We just don't know.
My final point was on the exit interviews, and thanks for covering that in your introduction. But the report actually says that the board will be getting a report this month on the outcomes of that review that was done by Law at Work, and we don't have a report on that this month, and that is disappointing. And you say it's hard-hitting and it's a difficult read. But actually, we need to read the difficult stuff, because if we don't deal with the difficult stuff, then nothing gets better. So I don't know how we're going to deal with that going forward, but I think we absolutely do need to have that as a minimum at the Workforce and Culture
Well, I was
Committee.
thinking, because we've got
Yeah.
May, that's the time.
We can do it at May in the work, and then we can summarise the actions arising from that coming into the board meeting. So if everybody's happy with that, then we can
It's
work
also
on
making
that
sure that we
basis.
can identify individuals, etc.
100%, absolutely, yeah, yeah.
It was actually discussed at the executive leadership prior to being referred to at the workforce report today, and it was felt that the full copy of the report would be available to the board following this meeting.
Okay. Well, thank you for that, and I think what's really important is the action that comes out of that,
Correct.
isn't it? Yeah. Great, so we'll bring that action into the next board meeting, that's great. So Bill, once again, thank you very much for what you've done, and whilst you've been here, and good luck for the future. Thank you. Okay, so if we are running a little late, so if we could just bear that in mind. Orby, over to you.
I'll just highlight the key points. Taking the report as read, I think the key issues I'll highlight is, first of all, where are we now? As at week 3, our deficit position report is 5.4 million versus budget, which gives a monthly headline run rate of every month a deficit of 1.8 million. But that the important metric is what is the trend, the trend that we are experiencing against our available funding. But the underlying position is that there are one-off items and exceptional costs in there, which you will remember from our previous report, of things like back pay that we've had to pay on the doctor's back pay, but also on previous year's costs that have been hitting us. So if you adjust for that, the underlying trending run rate, which is our operational deficit, which is recurrent every month, is 1.5 million, giving us a 4.5 million. 5.5 is the headline rate, underlying run rate is 1.5 million each month, which is 4.5. So exceptional costs of 1.3 million in there. In terms of what FRP savings delivery within that number that mitigates some of these pressures is we've delivered 1.82 million as of the 3 months so far against the plan, original plan of 1 million. I'll give a bit more insight into that. Whilst that is positive news, the factors underlying that though are that we are looking for mitigation schemes to deliver the original plan. And of course, as I highlighted in last month, that the reason those mitigations are required is one, no plan ever, however it is, ever goes to plan. So you're always looking for new ideas, new schemes, but also because of the underlying delays in some of the key enablers to delivering the savings and efficiencies as Bill has highlighted in recruitment, retention, workforce, as well as in the procurement area, which have been delayed, and therefore we have been looking for additional schemes to mitigate that until those enabling factors get into place. Chair, did you have a question? Sorry, you read it now. So we are constantly looking for down ways of mitigating the pressure we know is coming down the line. But that's the nature of turnaround. We'll put the enablers in place, we'll accelerate these savings. If we don't, in the day, if we have done, we'll have to find other ways to do it and do it safely. And that's the big challenge. That's what we're doing it safely. But the good news is we have managed to mitigate this pressure by finding, against the original plan, it was £1 million. If I look at the original schemes, we delivered 947 against those schemes, which we were slightly short. But then we found other schemes and mitigations of 900,000 to more than make up for it. However, going down the line, the thing to highlight here is going down the line, that gets more and more difficult. So I do expect from Q2 onwards, we're beginning to start falling behind, as I've highlighted before, because of the delay. But we'll do absolutely everything to continue to mitigate, continue to find new things to mitigate until we get the basics in place, as Bill has highlighted. The biggest basic is we need our own recruitment team to do the recruitment and the administration. We need that, and and we're still fighting to get it. We're 50% there because the recruitment is two parts. One is getting something to an offer and then onboarding. And those two, we've got the first bit in place and the second bit we're still fighting for. So we'll continue to find mitigations. In terms of where are we going? So that's where we are right now. Where are we going? Forecast remains at 18 million, unfortunately. We are working hard to continue to mitigate it. It's too early to say at this stage, given the risks that I can see coming down the line, to begin to bring that forecast down. It's too early. There's still too many risks. There's still too many dependencies, and we're still fighting to find them. So without going into, I'll take the 18 million is made up of budget pressures, slippages in FRP delivery, which we're trying to mitigate, and one-off exceptional cost and items from previous years that have hit us as well. Mitigation schemes, as I've described, is we're finding new schemes all the time. Examples are income generation through private income, but also controlling budgets and making sure where we have underspends, we hold on to those underspends and we don't spend that way as possible. But drug control on our rotas and our practices is again one of the key things that we need to deliver. So our forecast remains at 18 million, but there are mitigations we are trying to work on to bring that down, and we're very hard to do so. I will, just as a plea to the board, we are trying to fight hard to put those in place. We're not sitting there waiting for manna to come from heaven. We are trying to break down those doors and say we need our own team, this is what we're going to do, including with the support of executive, the chief officer and the board of saying we're actually going to go at risk in these things. However, I do need to highlight even going at risk is not entirely our control, because we still have to go to get permission from SET to do certain things. So whilst we will still do that, or if to bring people in, we still have to go and get permission and approval from the centre to do so, which adds a number of weeks, which adds a number of things for which you have to find mitigation. So I just want to highlight that we are doing both those things, is get our own, on the workforce get our own resources, on procurement get our own resources, but even getting our own resources there is mean you still have to go and get approval, which does delay. So we continue to work.
Thanks for that, Obi. Now, Julie or Tony, do you have any questions? Yep.
Yeah, okay, thank you very much for that. Personally, no finance or accounting expert, but I feel assured by the energy and efforts as going into understanding exactly what's happening, what are the drivers, and what are the risks and mitigations, and so on, really. I think as the board, we need to be very clear and be able to assure the Minister and his colleagues of the absolute drive for efficiency wherever we can find those efficiencies that are not impacting on service delivery. Because once it's impacts on service delivery, it becomes a political issue and must be exposed and lifted in an accountable way. So that's the first thing. And the second thing is we're back to, and I know I'd like a crack record on this, and I ain't born myself to be honest, but out of hospital stuff, the longer term solution to this is get much of the out of hospital right, so that we're reducing demand on the hospital and that we're getting people out promptly, safely and comfortably. And that's the work that Julie and I as the NEDs, in addition to everything the executive's doing, want to work on together.
Tony, you're absolutely right, and part of a lot of the focus of the SLT is around what we would call quality impact assessment, so ensuring that any of the savings that we're trying to achieve does not impact on services. I think one of the things from, maybe just to explain, that I think the integrity of the FRP is still there. Obi's explained about delays that are caused by just a resource that we need or provided by others is not moving at the pace that we are. But it's not to say that those savings are not there to be had. I suppose in the simple terms, we're all very familiar with local costs and the need to recruit and reduce that. That is, in effect, a waste of money and also not the best quality. So quality and finance are not mutually exclusive. We need to achieve both. I think from the point of view of the mitigations, that is the things that we're considering, and there are issues there which we will need to probably bring to the board and indeed to the ministerial team, because I, as an accountable officer, have a legal duty to deliver the financial plan, i.e. not to be £18 million off, and under the public finance law, that's something that I need to bring forward ultimately to ministerial colleagues about what those options might be. But it's true to say that some of the options that we're having to think about would require some very difficult decisions, and unpalatable, quite frankly, to make. So, it is a difficult situation, and I know the Minister's very keen to help with addressing some of those financial issues, which is obviously enormously helpful for the board.
It is. I wonder if we could be more helpful, though, or more assertive about the position to be helpful, because, you're talking about, we've been talking about recruitment now for 4 months, and you say you're halfway there. You're not going to make your savings on recruitment that are in the plan. We're behind on the income generation target that we've set as well now. You might be able to recover that, we don't know. So, I think it's great that you're managing to keep it at 18 million, because I think, if you weren't really mitigating absolutely everything, then that 18 million would be increasing because of some of the delays and the non-achievement of the savings or the income generation that we've highlighted. And as colleagues have said, I agree with the savings quality impact assessments, and I think at some point we need those here, and they need to be transparent and open about it, and the public need to know about it as well. However, that then becomes extremely political, very, very political, and we know definitely that the Minister and the other deputies, the assistant ministers, are very clear that they would want to try to rectify the situation, the financial situation. So in some respects, I'm almost asking for advice from yourselves as how we, as the board, can help with that situation. Is there anything we should be doing? Any advice? Our advice would be that the 18 million is not doable without having serious implications. And therefore, there needs to be political conversations about what the implications are and whether that the 18 million could be ameliorated in any way by the government. Now, as I say, that's all very political. I'm not a political person in any way, shape or form, but it does need to be sorted. We cannot go through the rest of this year because, as you say, you have a fiduciary responsibility to deliver the budget you have been given. And at the moment, it would appear that that's somewhat impossible. So we need to sort it out. And I know that the Secretary of State, I know that the Minister Tom Binnett is very, very keen to sort something out about this and is doing so. But if we can be more helpful as the board, then I would want us to be so. And if we can be more assertive about it, then I think we should be so as well.
No, I agree. I think you're right. The 18 million is a forecast that we're just trying to ensure doesn't grow. I think that that there are challenges, and I think the view of the board, and we need to sort of provide probably some more information around that. Delivering the 18 million would require, I don't think any of the executives around the room that have been involved in these debates that we've had would disagree, would require some very unpalatable decisions about clinical service, and clearly that is not, will not be acceptable to us as a board, and indeed I'm sure not to the politicians or the public of Jersey. So I think we need to get to the position. I think your statement though today, Carolyn, is going to be minuted and therefore is not unhelpful in itself.
Okay. So I think where we are is that, the conclusion of this discussion is that as a board, we support the Minister's view that additional funding will need to be given in this financial year to help us through the situation. That does not mean that we will not deliver every single efficiency that we can. that does not mean that in the long term that we will not seek to find better ways and more efficient and cost-effective ways of doing things. But that's just a recognition of the fact that the situation in 4 months in, that £18 million figure has not changed.
Yeah.
So I think it would be irresponsible of us not to raise it more formally. And so I think if we minute it that we do want to raise that more formally and support the Minister in his pursuit.
I would just say thank you, Chair. Thank you, Chair and colleagues. What my plea is that I think the support that we need is the belief that we back the programme here, which is the FRP programme. It is a quality-led financial improvement programme. Keep emphasising it balances quality, it balances money. And what you're doing there, it's complex. Healthcare is complex. We all know that. I'm working with the front line all the time. It's the clinicians we talk to, it's the doctors, it's the nurses we speak to, and to how can we make this happen. And of course, there are tensions in doing that. The financial recovery plan is our way out to sustainability, whilst running quality and making balancing finances. I think what we are saying here, in my view, would be long after Chris and I and this team are gone. I think this is the legacy we leave behind. Is that there is a very clear roadmap that describes that. I don't think anyone else coming could describe this differently, which is if you balance quality and good care with the money, there is a plan to do so. But unless you put the enablers in place to do that, it will simply take longer. I think the political will and the belief in we need let's support us put those enablers in place, which is HCS needs to control its own destiny. It can't keep asking for permission to do the right thing, which is we will recruit and we will recruit and we'll recruit fast. You can hold us to account to do so. But don't tie one hand behind our back and expect us to do so, and then tell us to deliver the money and keep the services safe. We will never cut costs by making things unsafe. I will never allow that, neither would Chris as a finance director. We're here to serve patients, but we need to cut out the waste as well. So what we need is, can we cut through the politics and get HCS to own the resources it needs, please? Invest in those only so it can drive its own destiny and will deliver.
I think we all agree that will be the issue is by the time you do that, it will be 8 months in and we still won't be. And so that's the real issue. Longer term, there is a longer term strategy. We're clear what the longer term strategy is, but we've got a short term, this year, in the year issue, which needs to be sorted. So yeah, I think on that basis, because we are now running, it's my fault entirely, we're running quite late. So if we finish it like that, that's great. So we will take the next report, the People and Culture Committee, as read. It's a very short report. It doesn't need any introduction, so we'll just take that report as read. At which point, the agenda says we have a comfort break for 10 minutes and we get back together at 11:15. So people, you've got 1 minute for the comfort break on that basis. But seriously, we have a 5-minute comfort break and come back together at 11:20 and we'll make up the time as we go. Okay. Excellent. Right, so our next report is yourself, Jessie, which is the nursing appraisal report.
Thank you, Chair. I'll take the report as read, but just highlight some of the key areas. First of all, recognising in Bill's workforce paper that there was an overall 27.5% appraisal rate. I just want to go through the paper, recognising that because this paper has solely concentrated on nurses, midwives and healthcare assistants that were on the Connect system. So looking at when we did our peer reviews, some information came to light as well that some people were still using paper-based systems. So I've taken that into consideration in my overall compliance rate, which for nursing is sitting at 54% at the moment. Now that is, I've taken into consideration objectives set and objectives agreed because of the way the Connect system works. Some staff had not pressed the button on the second occasion to accept and agree those objectives. Also what I have done since we wrote the paper was to look at there's a number of staff, because this concentrates in the first quarter of the year, the number of staff that were on long-term sick leave and parental leave, because they will not have objectives set at this point in time, and that was another 5% of the staff that were on Connect, so bringing the percentage up to 59% had those people been at work, which some of them may not be in work for quite a significant part of the year. So we did an in-depth look across our appraisals for our nursing midwives and healthcare assistants. It's really important we get them all appraised. Challenges remained across the organisation is the alignment of staff. So we had staff sitting in groups where they shouldn't be, so they're not aligned to their manager, which makes it difficult to undertake the appraisal. So we have weekly lead nurse meetings, and those meetings are to concentrate partly on appraisals and ensuring that we encourage and support our managers to ensure that staff are aligned to the correct line manager. I would want to say that some of the areas are really well appraised, and they are greater than 85% of staff completed appraisal, and there's other areas where there's less than 50% of staff, and the lead nurses are doing some targeted work with those areas to ensure that the staff are trained in Connect and that we are putting appraisals onto the Connect system and not onto the paper-based system which they were used to. So at the moment we're doing further training with our staff. We're cleansing the data to ensure that everybody's aligned to where they should be. And we would like to have a better position. I know 54% is, quite a lot of staff, but there's still another percentage of staff that need to be appraised, and that would be our aim, is to continue and help improve the appraisal situation for nursing.
Well, it's not great, as you say, but it's twice as good as the rest of the HCS, so I think you should be commended for that, and I think you should be particularly commended for bringing this report to actually go into the detail on it, and I think, folks, that's good practice, and that should be repeated across the piece, really. What is interesting is the point that you raise about the 85% and the less than 50%. So what is actually happening is some senior nurses are doing their jobs incredibly well, and some, they might be really good medically, etc., but they're not doing their jobs as leaders as well and managers as well. So I think, that's for you to know where that is the case, and you to deal with that as a part of their appraisal as well. But I do think that if you choose to be promoted and to take a leadership position, then there are obligations that go with that, and you have to fulfil them. And if you don't, then you are not performing your job properly. And I think we need to be quite tough about this, quite generally really tough about it, because it is really tedious and boring writing up an appraisal. It is actually. I mean, I've done billions. It's really tedious writing it up and then logging it, etc. But it's a part of your job, and people should just get on and do it. And I don't think there should be any excuses at all for not doing it. So I think we've got to be really, really robust with managers about this across the whole service. And it's not just nursing, because you've got some fabulous nurses, senior nurses, who are doing it all and leading well, and others that are not. So we'll leave, Jessie, you to deal with that appropriately. Bill, do you want to come in?
Yes, please. We've now made Connect performance appraisals a standing item on both the executive team and the senior leadership team agenda. And given the powerful messages coming out of Jess's report, I think what we should be basing it on, the point you raised about leadership and getting things done, is we should be asking Jessie and her colleagues to come along to some of these meetings to say, this is how we've done it, this is what needs to be done. Why aren't you doing it? If we can do it, why can't we do it across HCS?
There's a peer review.
Yeah. The other point, an adjunct, and it's a quick one, is that this is also highlighting part of the issue that because we don't have our own training budget, we're not developing first-line supervisory managers in the art of leadership and management, and also getting things done and understanding these important conversations. We take it for granted that because they're appointed into a position, should be skilled enough to do it, but we're not tracking it, we're not measuring it at all. So, there's room for work to be done there.
That's good to know. So thank you for that, Jessie. So we'll move on now. We're catching up on time, so we need to be conscious of it still. We've got the maternity improvement plan, Patrick.
Yeah, so I'll take the paper as read. Obviously, this is a monthly report, so just highlight areas that are changing. Just to provide assurance that whilst no further recommendations have been signed off, we continue to monitor progress on a weekly basis, and we can see that there is progress even though they haven't been signed off. The leadership team have been focusing this month and next month on culture in particular, and also the development of the maternity strategy. And that will lead into developing really the maternity improvement plan phase 2, and that's really about sort of staff engagement, but also input from service users, particularly the Maternity Voices Partnership. In terms of making sure that the improvements are embedded, we continue with the 30, 60, 90-day follow-up, and that has progressed. So last month there were 70 out of 99 recommendations have been reviewed. This month is 75. There are areas where we're not assured that the changes have been embedded, so that is, where that is the case, we stretch it out further and review at 120 days. Excuse me. So making sure it does become business as usual. The Picker Institute survey, we have the results in, and obviously we're looking at that as an executive team, but that will return. But certainly the results within maternity services were very encouraging, and good feedback from patients through that, but more detail will be brought back. I mentioned the massive obstetric hemorrhage already, and finally just to good news in that we have now appointed to the practice development midwife and a maternity governance midwife, which will be very helpful, and those 2 members of staff are expected to start in July, which will help push on the quality improvement agenda in maternity.
Right. Thanks for that, Patrick. Julie?
Just a couple of quick points. Hope that won't whistle. I mean, the first question was just to say I really welcome the idea of benchmarking against the SHIP Integrated Care Board. I just wondered whether we could also do some benchmarking in relation...
Could you switch that off? No, you turn that one off and I'll turn this one on.
In relation to Guernsey and the Isle of Man, just to get some comparisons around the particular challenges of providing high-quality maternity services within island systems, I think would be quite useful. And the second point, is there any update on the consultation, on the recruitment of consultants? Because I know that we've got locums at the moment, and we also don't have a substantive clinical lead for the service. I just wonder if there's an update on that.
So I'll start with consultants and then maybe hand over to Kathy in relation to the benchmarking. We've had one round of attempting to recruit for consultants, and we didn't have any what we considered suitable applicants. We are going out again, and I think we're due to re-advertise any day now. So it's where we're looking for help externally with that to encourage the right sort of candidates to apply, and when we are thinking very hard about the way we will have this clinical leadership, particularly medical clinical leadership, and we've been having conversations with the team in the last few weeks. Maybe Kathy wants to talk about the benchmark.
Thank you, Chair. I think there are 2 points there. Very much our Director of Midwifery, very much in close contact with both Guernsey and the Isle of Man. I think it is worth noting that SHIP, Southampton, Hampshire, Isle of Wight and Portsmouth, and that does include the Isle of Wight, which is 12 miles by 24, has a population of 148,000. So an island with those island challenges, which is one of the reasons why we chose to, but most definitely comparing benchmarks. And Chair, may I be cheeky? The medical director did say we haven't seen an improvement in the recommendations. As of yesterday, we'd achieved 100, so that was actually to say that under the medical director's chairmanship, those meetings are happening each week. We are moving with traction with those recommendations. So we hit the 100% change.
I think that's great. Now, at some point, I think this needs to become business as usual rather than constantly, particularly if you've completed 100 recommendations. So I think we need to have a think about that. Ordinarily, you know, maternity would be reporting to the quality committee in detail when that meets, and I would have thought we can go back to a business as usual basis for reporting through the quality committee. One of the things I haven't seen here to the same extent that I have in the UK is the issue of stillbirths and mortality, etc., you know, brain cooling, all of those different issues. I know there's a much smaller number of births, but I think, you know, it would be good to see that regular information that you would get about maternity services in the UK reported to the quality committee. And because what's particularly important, I think, about when you look at those issues in stillbirths, a lot of those stillbirths are the very same women who did not attend appointments for antenatal purposes. They're usually women, it's said in the UK, who can't speak English, or from poor and deprived communities, and therefore what we've got is an issue of health outcomes which are not equal. So we really need to be addressing those issues as well. So, but I think in terms of this improvement plan, well done, you know, but it should go to the quality committee, I think, as business as usual, but I think you do need to be expanding on some of the issues that we would be seeing elsewhere. Yeah.
Sorry. I agree. I think I still want to see the maternity improvement plan group meeting every week, because I want to ensure that these are embedded, and I don't want us to take our foot off the gas from that point of view. I think, Ryan and I've asked about things like neonatal mortality rates, which is something I'm used to, and I think and I know Simon Mackenzie has commented on this, the sort of benchmarking of those with such low numbers is actually, in Patrick, it's very difficult, but your point is well made around, you know, those that we do see, understanding the causes as well. So, but I think having a monthly board paper, if the board are happy that now goes through the quality committee, that would be fine. But I think from our point of view and from an executive point of view, we want to keep the momentum going until we're assured that it is embedded. And as Patrick said, there are some significant cultural issues, and there's no point pretending there aren't, in that area that we are working to address.
But certainly those areas you highlighted, in cooling of babies, we would expect those to be reported to the Serious Incident Review Panel, just so that we have oversight of them. But you know, so the low numbers means trends are difficult to understand, but we would look at individual cases.
Yeah, okay, and I certainly didn't mean to imply that you shouldn't be on top of it, dealing with it and embedding it, no, so, but good, I don't think we need a monthly report, there's so little variance really between the two. Maybe we should have a 6-monthly report to the board going forward.
Chairman, just to pick up on the point about stillbirths, the Jersey Giz does form part of Embrace UK, and you'll be used to the Embrace reporting. And in fact, that does form part of our weekly and quarterly monitoring, have we reported any statistics to Embrace. For those that don't, Embrace is a national reporting database which looks into mothers and babies who've had losses as a result of poor care, and Jersey is now part of that. So as part of that reporting, we do follow up on that. But as Patrick says, fortunately, because we have such small numbers, you know, but we're very much on top of that.
Brilliant, thank you, Julie.
Just to say, I support the reference of this to the Quality Committee, but could we also refer the specifics around clinical recruitment to the Workforce and Culture Committees? I think we need to just keep an eye on that as well.
Yeah.
Great point, thank you very much for that as well. So I think on that basis, we move now on to the Medicine Improvement Plan. I think that's yourself, Claire.
Thank you, Chair. So just to put the paper as read, what we recognise is, so we weren't initially expecting to bring a paper to board this month, and we've commissioned a review of the action plan, so very much to follow the themed approach that you'll hear discussed in the maternity work. So apologies to the board that I can't sort of bring more
definitive position and assurance around our current position, but it's really a briefing note to describe the ongoing work. May is quite a crucial month for this piece of work. We've got the onboarding of some additional capacity to really support both quality and safety performance turnaround, with the arrival of a physician from the UK to support our quality improvement work. We've got some additional operational capacity again starting in a week or so, and also using our project improvement coordinator that's led Livy with work in the maternity, again to obviously support our action plan and looking over our progress. There has been quite a significant meeting during the last month. This was to respond to a particular recommendation about the model of care for our enhanced care area that sits within the AAU, and there was good representation both from our intensivist and acute physicians. We very much listened to and responded to the Royal College of Physicians standards and the documents they signposted us to provide the framework for that. So that's going through the Medicine Care Group Governance Programme. We're still mitigating risk in the same way. So obviously we've had discussions that we do have 5 key areas that are currently resourced. I think we described at board that we know that the medical model actually needed further resourcing, but we've been unable to date to obviously secure funding and talks to the continued sort of financial position. But we have got interviews scheduled for a week or so. We've got some really good candidates. So again, that will bring some substantive capacity, we hope, to the area and support the ongoing response to the concerns raised by the Royal College. So happy to take any questions, but just a bit of a briefing position, I think, for now. Go on, Chris.
I think this is a key priority, and I think I would recommend that this does come to the board on a monthly basis. That there are serious concerns raised by the Royal College reviews that have been to this board in the public domain, and we have to address them. This is a core service, acute medicine, for people of Jersey. It's an emergency service in that respect, and therefore we have to get it right. And being in a position where the Royal College of Physicians describes us as providing largely poor care in this area is unacceptable, and therefore has to remain a key focus for us and indeed our clinical colleagues in this area. I know, Patrick, you are concerned about this area as I am, and I'm sure everyone shares that concern. So we have to keep this as a priority and therefore bring it back to the board on a month. Every time it's a board meeting.
Yeah. So I think we definitely, yes, I agree. This report, doesn't really take us a lot further. So I do think in May, we should not just have the action plan, but we need to understand more fully who is being. So you talked about a service redesign. How are we consulting with our existing staff on the service redesign? What are their views? How many staff are involved? How many of them have been involved in the consult? As a whole, how many have been involved actively in the consultation? At what levels? So I think we really need to understand this in some detail in terms of how people are being taken forward together to make this a success, because we are aware that there is contention in terms of what the Royal College of Physicians have recommended we should do. And what is practical within our resource allocation. Just because the RCP have said you have to do this, that and the other, if we can't afford to do it, we've got to find the best way possible that we can meet their concerns within our resource allocation. So I think at the next meeting we need a substantive item with a decent, a bit of time allocated to it, so we can have a proper discussion about it. A bit of a deep dive into it. I think that would be really helpful.
Thank you. Thank you.
Right. So on that basis, let's move on to the patient experience. I think that's yourself, Jess.
Thank you, Chair. I'll take this paper as read. This report concentrates on the first quarter of 2024 and has some comparison data in it from the same period in 2023. The team have been reorganising the way they work and are concentrating on early resolution of complaints and concerns raised by patient relatives and carers as their key priority. They have changed their internal processes to focus on reducing escalation to formal complaints by working with departments and wards and staff to support de-escalation of resolution to complaints, potential complaints. It's important to note that we have reduced the time it has taken to respond to those formal complaints. We've reduced it from 54 days in Q1 of 2023 down to 15 days in Q1 of 2024, and that's due to the hard work of the patient experience team, working with the care groups and the senior leadership teams on a weekly basis to review any open complaints and identify blockages to responding to the complaints so that we can close them in a timely manner. Overall, complaints are down by 64% on year from the same period of last year. I want to just touch on the patient advice and liaison service. A lot of work is going on in the background for that service. It will be formally launched in Q2 of this year. We've got new branding uniform for the PALS officers that you'll see at the front of the hospital and around the wards and departments. A media campaign to highlight the work that the service offers, and the aim is to relaunch it so that patients, relatives and carers fully are able to contact the PALS team and know what the PALS team can and can't do to support them, so they can listen to their concerns, signpost to departments for resolutions and provide advice and information relating to HCS. And they will liaise with various departments on the patient's behalf. So that is ongoing work, and we've had some real positive feedback from that. Work's being carried out with the team to ensure good engagement and communication with the patient's relatives and carers who want to log a formal complaint, so that's signposting and helping with the complaint for people that make contact with the PALS service, so they will support that through to feedback. Risk and issues, we still need to do some work on learning from our complaints and feedback. That's crucial to improving our services. And within this report, we have some lessons learnt that from the first quarter of this year. So following feedback from patients, a working group's been set up to look at ways of improving patient experience for the deaf community, and there's a working group being set up currently for that, and that's as a response to experience that patients have brought forward from both the hospital outpatients department and the Edith Kennel Centre. Another suggestion was for a specific box to be set up in the emergency department, following feedback for suggestions from patients about the patient waiting area, and we'll bring those results back to the board. And we've done some targeted staff training following complaints relating to staff attitude. Recommendations is will continue in Q2 to establish a consistent approach to applying a decision as to whether complaints are upheld, not upheld, or partially upheld, and that is to bring us in line with the government policy that we abide by for complaints raised within HCS. We're continually working on our themes so that we can share monthly with the care groups at their governance reviews, common themes that are coming through and how we can resolve those themes. And just like to take a moment to say how much work the patient experience team have done in the first quarter of this year to improve the situation. Just like that to be noted by the board.
Thanks very much for that, Jessie. Anybody have any immediate comments? Tony?
Yeah, thank you again. Yeah, thanks for that, Jessie. Again, very very full and clear, and I think complaints is, you know, one of those key areas where quality and quantity need to sit beside each other really. We can get complaints down, but you know, the experience of the person going through the complaints process, or the de-escalation, which sounds really good, is absolutely critical. So the more we understand about that, the better really. I mean, it's good to see that focus on where we've got complaints relating to attitude. That really does need to be zoned in on. And that's not to prejudge. Sometimes people don't like what's being said to them with the very best of intentions, really. But it does need to be explored and understood, yeah, as you say in the report. But quality and quantity, let's sit side by side.
Just to expand on that, so that you're interested to look at exactly the same 3 points in reading the report. So for example, medical services and surgical services have a higher volume of complaints, and I assume they've got a higher volume of patients. But it would still be good to know what that is as a percentage. So if it's 49 out of 49, we need to be horrified. If it's 49 out of 4,900, we need to be concerned about the 49, but less horrified, if I can use that expression. And surgical services is 48 out of 30. So I think it would be really helpful for us to know what is it in terms of a percentage of the whole. It's really positive that it's gone down, you know, good, that's really good, well done. But we do need to know what that is a percentage of. And like Tony as well, when I looked at all the themes, the staff attitude one just jumps out as that is unnecessary. And, you know, I think you should be able to discount if it's just somebody not like being told what they're being told. But actually some of it will be staff attitude, and it will be, you know, it definitely will be. And so we need to know where that is, what it is. Going back to your previous report on appraisals, it would be interesting to know if a lot of those complaints came, for example, from the wards where there hasn't been appraisals, and start to, you know, just correlate all the different information and data that we've got, so we can get a really clear idea of where we've got pockets of really not great performance, so and not great leadership as well, actually, as a part of that. So I think, you know, thanks for bringing the report. I've heard some very positive feedback about the new people leading PALS, the person leading PALS, so that's really positive as well. Hopefully we can retain that individual, and then we can get into a really good place on this. So thanks. Chris, do you want to come in?
Yeah, I agree. I think the staff attitude is a big concern to me, and not all of it will be addressed by people not liking what they're saying, and that is, you know, in old-fashioned terms of customer care and good communication. And if you look at sort of complaints in the National Health Service, and certainly the ones that I've been involved in, communication is often central to the complaint, and if poor communication is the start of it, then other things follow on from that. So it is something we need to be concerned about. I think the point, you know, you said about context, it is important, because we don't, percentages are important, and remember that, you know, there will be hundreds of thousands, literally hundreds of thousands of patient contacts per year. You know, we see 200,000 outpatients a year. So we need to look at it in that context as well. So I think your point of joining up the dots, and particularly around appraisals and where the complaints are, I think is really important to understand where we can target areas for improvement. But absolutely, I think it's progress.
Great. Thanks for that. So I'm really pleased that we're now ahead of ourselves in terms of time. And I'm really pleased as well that Ashley McNevin, who's the Freedom to Speak Up Guardian, is able to get here early and at all even. Thank you very much, Ashley. Just before we start this item, I just wanted to make clear that the reason this report is here is because I personally asked for this report to come forward. And the reason why I asked for this report to come forward is, if you look at the Jersey Care Commission criteria and standards, one of the very specific standards is about people's freedom to speak up. And for us to be successful in that, there's got to be absolute confidence in people's ability to speak up, to do so confidentially, and we need, as a board, and as a community, I think, as well, we need to support all efforts to make freedom to speak up a success. And so we've got to do everything to be supportive of that, to make it a success. Because if it's not a success, well, you've got the immediate issue around inspection, but if it's not a success, then that's not good for our staff and it's not good for patients. So it's in all our interests, collectively, to make sure that the Freedom to Speak Up Guardian is fully supported to do her work. So I think it'd be really important in introducing the report, Ashley, if you can, you know, clarify exactly the issues around confidentiality and also your line management and your relationship with the executive here as well. If you're okay doing that, yes. Thank you.
Thank you. It's good to be here and have the opportunity to kind of talk about this again. So my role within HCS is independent and I offer an impartial service to all employees. In terms of my reporting line, that is directly to Tom Walker, who sits outside of HCS and is the Assistant Chief Executive of Government of Jersey. So we meet fortnightly on a regular basis. This afternoon actually we're due to meet. And we kind of, the role continues to develop and evolve. The National Guardian's Office sits in the UK and oversees Guardians in England. So we sit outside of that, but my practice is in line with what they require of Guardians in England. I have developed really strong relationships and developed mentorship through one of the Guardians who's now gone to work for National Guardian's Office and another Guardian who's in Southern Health. So it's great that any issues that we're kind of teething problems in terms of how we set it up in Jersey, it's helpful to talk through with those Guardians who have greater experience. It's more embedded in their relationship, in their organisations. So when people come to me, the limits to confidentiality are explained from the get-go. So they would, for anyone who is from a kind of allied health professional background, the limits to confidentiality exist to protect individuals, but they also serve as a protection around if there are safeguarding issues, if there's anything that may impact or harm somebody else, then we can't keep that confidential between myself and the person who's coming to me, and they're informed of that before they open their mouths. Because I'm really keen on letting people know what they're stepping into, because if somebody comes to me with an issue that's only impacting them, then I'll say, come on, just let's have a chat. Let's think about what's getting in the way of you doing your job, because the overarching aim of Freedom to Speak Up exists for staff to have a safe space to go to talk about things that might be getting in the way of them doing their job, but also to enable us as service providers to provide a safe service for our patients. So the key issue is in and around the confidentiality and how somebody might feel that they can do that well. So we speak about confidentiality and limits to that, and then as somebody's talking, I will write down what they're saying. They'll see me writing it down, so they're in agreement with that. After we've had our conversation, they go away, I type it up and send it to them. People are anonymised, they're not identified in the report themselves, they're not identifiable. The reports themselves are stored in number order, so only I know what that relates to. The storing of information, we've developed a Freedom to Speak Up Datex, which is specific for Freedom to Speak Up. Again, people who have experience of health organisations will know that the Datex system exists for reporting concerns, raising complaints or issues. The Freedom to Speak Up Datex is completely separate to that, and that only comes to me. It's beneficial because people then have opportunity to raise a concern through that, or they can contact me via the other streams that I'm contactable through. It provides a mechanism to store the information securely, and it also enables us to generate themes from the information that's coming through, which the board and obviously the leads within the health and community services will require. Because I explain to people when I talk to them, if we want to fix something, it's like a bit like a jigsaw puzzle. We need to open the box and we need to take the puzzle out so that we can fix it. So the reason then that the themes are then reported back into the organisation and the areas where concerns are raised, that needs to go back into the organisation so that improvements can be made. But people themselves aren't identifiable. The area within the organisation is identifiable because that's the area that the concerns have been raised in. So since I attended the last board meeting, Jessie has now been identified as the exec lead for Freedom to Speak Up. And again, that's in line with National Guardian's principles and guidance. Jessie's role then is to be the champion from the executive team to support Freedom to Speak Up, but not only Freedom to Speak Up Guardian, but Freedom to Speak Up as a cultural change. How are we going? Because again, when I explain to people about my role is one part of a culture change and a sea of change. So that's the other areas of development that I'm very proactive in thinking about. So there's two streams to my role. One is that interpersonal meetings with staff who want to have a safe space to talk. The other part is that proactive side of what is speaking up, how can we develop it, how can we encourage staff to go to the managers to speak up, and how then equally, because it's not just about speaking up, it's about listening. So as an organisation, we need to be thinking about how can we empower our staff, our managers to be open to understand and learn and hear what staff have to say. And they're the real gems of having a positive, robust, healthy, efficient speak-up culture. So that's the relationship between the exec team and that's the areas around confidentiality. Just as an aside to that, staff are also given the opportunity, so I just want to kind of clarify the difference between confidentiality and anonymity, because when people come to me, they are assured confidentiality. Staff are also offered the opportunity to report any concerns anonymously, so then I don't even know who they are, and they can do that through the DATEX system. I have to kind of highlight there's a barrier there in that if somebody, because we're so new, one of the main concerns, I suppose, any guardian would have in the organisation has is how do we know if the improvements we've put in place have been effective? So when people raise concerns anonymously, I can't go back to the person to say, okay, this is the plan, this is what's going to be put in place. Come back if it hasn't worked, but you can't do that with somebody who's anonymous. So the problem there will be that there'll be a huge sense of futility. What was the point? I raised a concern, nobody did anything. Things might have happened, but things didn't improve. So that's one of the issues around anonymous concern raising. I know you didn't ask that question, but I just wanted to clarify. Because people say confidential, but there is anonymous referral opportunity as well, but there's a limit then if people do raise concerns anonymously.
I was just going to say, just quickly on that point though, people can just create an email address with a false name and write to you, and then you can converse with them. So, I mean, that would be a good thing to say to staff. Just call yourself Jack and Jill or whatever. Okay. Sorry, Chris.
Yeah, I think that was helpful, Ashley, but again, just for the avoidance of doubt, some staff choose to get you to come and speak with me or indeed other directors about their issue, but they have to give permission explicitly for you to come with me with those issues. And of course, a number do, don't you? You know that, where we've been trying to address certain issues. But you will not come to me, that's just for the avoidance of doubt, or any other director, including Jessie as the Guardian, if there isn't permission from that individual or individuals to do so.
Yeah, and I'm glad you've raised that, because there seems to be more recently a myth around what's going on, and I'm really keen to kind of dismiss that, because the whole thing around speaking is the trust. And it takes a lot of courage to actually step across and say, this is the issue and I'm placing my trust in you. And then equally, when we're looking at the wider issues around freedom to speak up, I'm placing my trust in the organisation to try and fix this. So we need to work together, and I'm glad you've raised that, Chris, because the only time that a person will be identifiable to anybody else is when they give their express permission to do that. And then by doing that, there have been cases, like you say, where employees have been offered the opportunity to meet directly with exec leads, but only after they've given the permission to do so.
The other important thing, as you said, is of course it is just one in our overall culture of encouraging speaking up, which is so important for all the reasons we know. But it is of course just one route. I know, and I'm, as chief officer, I also know that colleagues, people come to talk to directors and to raise issues and concerns all the time. It happens. So it is only one route. It's a hugely important route. It's an important route that shouldn't be ever undermined by anything, because we want people to speak up. But people are starting, and my sense, having been here for 12 months now, is that more people are starting to come forward and raise concerns. Some of the things that we address on a daily basis are as a result of people raising concerns with us, whether it's about patient safety or bullying or a whole range of issues. But the culture of speaking up, which although Jessie is the lead director, is as important to Cheryl as part of the cultural chambering as it is to me as leader of HCS. So it is an enormously important part of improving the safety for our patients and also improving the staff experience of working in HCS. So, and of course I am used to, having been in the NHS, having a guardian system, in larger organisations, actually you wouldn't be on your own, there'd be a whole team of people, and I think that your networking with guardians in the UK from a professional peer support point of view is very welcome, and I would certainly support that.
I think it's worth saying that when the Freedom to Speak Up Guardians were introduced in England, they were treated, with quite a lot of cynicism about their independence. I think a little bit, to be honest, as is happening in Jersey as well. And that has been overcome with time. And now they are seen as a positive part of the framework within which everybody operates. And what I've seen myself as an NHS non-exec is how successful it is with the role of the lead NED working with the Freedom to Speak Up Guardian, giving them direct support. So not just the executive lead. If there was anything that the Freedom to Speak Up Guardian didn't really want to raise with an executive lead because it was a little bit too close to the bone, if I can, then
against the chief executive.
Well, indeed. Yeah. Then that, in that instance, then that can go to the lead NED, and the lead NED in our instance is Claire Gerardo. So that's a further level of support and in for yourself. You and I will meet as I chair the workforce committee as well. So I think, making sure that you have got enough support around you to do your job, and indeed in many respects protection as well. Protection of your independence is very, very important. So I think we all need to be very, very, very vigilant about that, to make sure that you are independent and you're seen to be independent, and then you can be successful in your role. So I think that's very important. And I think it's worth reflecting on the fact that you should be writing an annual report to the board. The annual report that was written by the Freedom to Speak Up Guardian in Birmingham at the Birmingham Hospital Trust resulted in that hospital clearing out its senior management and indeed putting the hospital in special measures. And the chair of the trust as well was also cleared out as well. It was an absolute clear out because the Freedom to Speak Up Guardian was seen by staff as somebody they can go to and raise their concerns, and the whole issues of bullying, favouritism, etc. was all exposed in their report, and the hospital then was in. If you actually looked at the medical outcomes at that hospital, they were actually very good, but it didn't matter. The hospital was placed in special measures because of the report of the Freedom to Speak Up Guardian. So I don't think that would happen here, but we need to create a culture and an environment where you can operate in the same way that freedom of speak up guardian was able to do so. Tony?
Yeah, I think that's the key for us. Actually, we need to know that, and this is an inherently complicated role, where you need the confidence both of the staff and the managers and so on as well, really. And that takes some, some really complicated and mature navigating times, I'm sure, really. I guess as the board, we need the assurance that you feel you're able to do your job. That's to me, in many ways, is the bottom line. Given these inherent tensions that are actually there. I mean, a big thank you for the way that you've presented that today. And, I'm certainly very confident that you understand the inherent complexities of this, really, and getting it right. But all credit to you, and thank you.
Okay, so anything else? So if not, I know you weren't anticipating being here, Ashton, so please feel free to go back to whatever you were doing anyway. Thanks very much for coming.
Thank you.
Okay, so I think at that point, we are... Wood assurance, sorry, I've got wood assurance, that's the late report. So that's you, Chris, isn't it? Yeah.
Well, it is, but I'm going to just sort of hand over to Emma, as board secretary, for doing a lot of the coordination work to talk about how we're going to use this, develop it, when we're going to see it as part of our board schedule. So, Emma, would you like to?
Yes, thank you. So this is the first board assurance framework that we've had within health. It's not unique, it's used quite widely in many kind of public and private sectors, but it's the first time that we've had one. So it links very nicely to our annual plans. So the exec team and the non-exec directors sat down together as a board to discuss their objectives for 2024. So following that period, they were mapped out, decided, and we looked at the kind of key risks that the organisation faces in terms of delivering on those objectives. In terms of risk management, this is a proactive arm. It's about horizon scanning and identifying and mitigating risks before they materialise, as opposed to the reactive side in terms of our kind of management of incidents when they occur. I think it's just important to note that this will develop over time. I think as we now kind of commence our rounds of committee meetings properly, and in full, their responsibility will be to look at deep dives into the key controls and assurances to make sure they are fully understood and represented accurately. So we'll really start to kind of get some flesh on the bones, as it were, over the next coming months. And I think what I've included, and I think what's key to this as well, is now that we've produced a document, it isn't just a case we've got a document, here it is. It's about its continued use and recognising its value. That is a challenge that does present itself to a lot of boards, so I can't take credit for the series of prompt questions I'll be proposing that we use in committees. They come from some brainstorming across a board network that I'm part of, just making sure that we are always thinking about what the objectives are, what our key risks are, and how that risk level is changing across the piece. So I think we've got a lot of work to do in terms of maturing and make sure it becomes part of our business as usual. I don't think it's a tool actually that we would just limit to our kind of board and committee structures. We could be thinking about the risk detailed within the board assurance framework at some of the senior management meetings and meetings going on. Some development work, what we'll do is, obviously a board assurance framework is a top-down approach to risk management. We also have the operational risks that come from kind of the frontline services and up. And what we'll start to do now is to link some of those operational risks to these overarching key risks. And I've also, what we've included on this is, once they have been fully agreed, we'll start to link to the JCC domains as well. So again, we'll start to prepare for an inspection, and we've constantly got that in the forefront of our minds as well.
I think we're all very grateful to you, Emma, for the work that you're doing on this, because it is actually a fundamental part of all board assurance, and all boards should have an appropriate assurance framework. When do you think you'd be able to bring to us what it was? I mean, if you look at the well-led part of the Jersey Care Commission, I say well-led, that's an English term, but you know, that bit on governance, etc. You know, having a proper risk management board assurance framework is really, really important. So when do you think we'll be able to have it here and start discussing it in greater detail?
My hope is that we see this every single meeting of the board.
Yeah.
So we'll have it again in May, at which point we will have we'll have some of the assurance committees, so we'll start to build on that. But it should be on the agenda of every board and certainly of the assurance committee.
We'll also go and take it to the SLT because we need to ensure that, you know, where we feel there have been changes in the risk levels or risks of change, that we're able to feed that up through to the board. So that will feature as a monthly review. Sometimes it won't require any change at all because we just need to make sure that we're on top of it. It needs to be used. It is a sort of dynamic document. It's not something just put on a shelf. And is a central part of, for those that have worked on boards before, central part of how we manage the board in effect, business of the board.
Good, all right then. So I think next time we should, you know, put a bit of time for us to really go through it properly, and let's put it at the beginning of the agenda as opposed to the end, just so that we make sure that we give it the time that is required, because it does need a proper conversation. Brilliant, lovely. Everybody okay with that? Good. So at that point, I think we can take any questions. We've not been given any questions in advance. I see a lady with her hand up. If anybody wants to ask a question, you can put your hand up now, and then, so that's 1, 2, Brad, okay, so I'll ask the lady here, 3, Angie. So 3 people, so you were first, so.
Okay, mine's about financing and pharmacy really. I've just come out of hospital. I took all my medication in. None of it was changed during the 2 weeks I was there. They gave me my medication from the pod the 2 weeks I was there. When it came to me being discharged, that medication that was in the pod got returned to pharmacy to be thrown out, and they re-prescribed the medication from the hospital pharmacy. 5 parts of that prescription were missing, and that was what I got sent home with. Now, what a waste of money. And you're saying you're trying to save money.
I agree with you. Does that make a waste of money? I'm not quite sure.
And there is also 2 pharmacists on the ward. Why is there 2 pharmacists on the ward if you're having problems downstairs with long queues and stuff?
Well, pharmacists do need to go on wards. There's no questions that pharmacists. It might be that one was new and training and being trained on how to. We don't know the detail, but I think your general point is that what happened there was a waste of money, and it was.
Yeah.
And so I think you need to take that away and make sure that that doesn't happen again.
We have pharmacists and we have pharmacy technicians, so one may have been slightly different role.
Well, it's 2 people doubling up, isn't it? But I'm sure it would have been because for some, anyway, whatever. I mean, they're so stretched. We all get emails about how stretched they are. I don't think they're going to push 2 people on the wards, you know, other than without reason. But that apart, the issue about the prescribing and throwing away of medicines is absolutely ridiculous. So thank you for raising that.
We can pick that up.
Yeah.
Thank
you. So, gentlemen here.
Really just some observations from today and previous meetings. First of all, on workforce, there's been a lot of debate about recruitment process, how long, how many unnecessary steps there are, and also the retention of staff. And I just wanted to flag up, there's a group of doctors that are in the system that are known, who have applied for jobs in Jersey 6 weeks ago. They were told 3 to 4 days they would know the outcome. the advert was incorrect, and 6 weeks on, some of those individuals don't know. Surely we should be trying to retain those people. They've been screened. They are people that the service wants to retain, and yet they're being left in limbo, and potentially, because obviously the clock is ticking, and we'll be looking to the UK. So I really think we need to, I know, you've spoken about having more control within, but this is something that can be dealt with very, very quickly, and will, have a positive impact.
Well, I'm just wondering, Bill, because that's very important, that shouldn't happen. Maybe Bill, after me, can pick up where that is, so Bill, you can get onto it and see what the delay is.
Okay, yeah. The other observation was really regarding appraisals, and it's great to hear about the work that's happening. Although, just a couple of warnings from, I've spoken to quite a lot of clinicians and managers. A lot of people feel under immense pressure to get these done. And a couple of managers have mentioned it's a tick box exercise. We need to get them done. So the focus on individual performance is not always as it should be. And in my mindset, that's quite dangerous, because if we're praising people and we can say, come the day 100% people are appraised or whatever, but if we haven't looked at their fundamental performance, is a concern. Linked to that is objective setting. I fully get why corporate objectives need to be used, but in some instances it's pure corporate objectives and frequently being repeated. And managers are under pressure, they've got to demonstrate they're doing them, but when you kind of unpick and look what's there, the objectives are not going to kind of enhance that individual's...
Yeah. And that's so important, because that's sort of what you call it. It's hitting the target and missing the point sort of issue.
Exactly.
The quality of appraisal is also obviously hugely important. It's not, it can't be just a tick box exercise. The quality of appraisal is important. We're certainly doing some work, Patrick, aren't we, on improving the quality of medical or of consultant appraisal, because it's not, or doctors in general, because that's just not as strong as it needs to be. But you're right, no point doing appraisal or set objectives that are meaningless just to tick a box. They've got to be appropriate. I agree.
My final point, to be brief, finances. Again, hearing about the concerning financial picture overall, I really urge the exec to scrutinise the way overtime or locum shifts are authorised. In certain areas, and a couple of consultants have raised that not the most appropriate resource is being used, and quite often a higher grade is being used when a lower grade could be used. And whilst there are rota coordinators, they seem to have mixed amounts of control. And obviously, when it comes down to it, there are limits.
Absolutely. Obi, do you want to come back on that?
And then Patrick as well.
Spot on. It is exactly what we are doing when I describe the controls which we put in place. The financial recovery programme, one of the key work streams in that pieces of work, is exactly based on rota compliance, and that is about going through understanding how those rotas are to put 6 weeks out, and look through those and scrutinise through safer staffing, making sure they're safe and they're appropriate, but also do they meet the financial disciplines into. Some of the issues you've raised, we are very well aware of that. That's exactly what we're targeting.
But there are things that could be done today to rectify it. And it's about good operational management.
You're absolutely right, and that's exactly what we do, but I'm sure if you've ever managed these type of things, then you would know that doesn't happen overnight when you're looking at...
I have managed these things before, and a lot can be done by good operational management.
Precisely,
which isn't currently apparent.
Well, I think it's a really important and sensible point that you've raised, and I think I know you're on it, but I think just drilling down, so it might be that that's not yourself, will be, but that is more the individual executive director leads to make sure that the right people are being given the overtime, and it's really important to make sure there is no favouritism as well, because staff know immediately if there is favouritism, and it creates huge disharmony. So I think that's down to everybody around this table as an executive to make sure that that's dealt with properly.
Aware of it, and that is basically. So I think I'm aware of the issue raised and it is being addressed.
Okay, right, well, you're obviously speaking in code.
Amen.
Yeah. Excellent, thank you. Jean?
Yeah, mine also is about pharmacy. It's basically, given that we have the resignations that we had about last month, how do you manage replacing those people, given that, as you said earlier, you can't advertise a job until the person's actually left? So that leaves a gap, surely.
Yeah,
you know, pharmacy
Jean,
gap.
well, we can't afford a gap, can we, in pharmacy?
No,
so I agreed a month ago from now, so for some additional staff to be employed in pharmacy now. What that means is, of course, we have to rely on agency to get people in quickly. We rely on agency pharmacists at a premium rate, or pharmacy technicians at a mix. So what we would do is look to appoint, I say, whilst we're recruiting, cover those by agency or local pharmacists, as long as we can get them. You know, it is about attracting people in. So, you know, where there are critical areas, and you know, that's one of the things that adds to the bill is the speed at which we can recruit. And even if we were quick, we know that, you know, in the same in the UK, recruiting pharmacists and pharmacist technicians is one of those areas that is under particular strain. But no, we would cover that, and have, I think, I'm just checking with Patrick, employed some agency pharmacists or that may have not started, but to cover those gaps.
So anything else from anybody else? So I've got a lady here.
Hi, I'd just like to expand on the recruitment. I'm currently a junior doctor here in A&E. So I'm from Jersey and very much proud to be. I was just come from the NHS as a junior doctor there, and it's, you know, public knowledge, like how things are over there, pretty much a sinking ship. I was very much considering leaving the profession, but so I'll see how it goes in Jersey. I've had to just be so proactive in terms of the HR side of things about getting a job over here. I think I had my interview in May. I came back on the ferry at the end of July with no rota, no contract, no job role. I didn't know where I was going to be. I had nowhere to live. Thankfully, my parents do live here, so I did have somewhere, but they didn't know that. I know several other doctors that have gone elsewhere just because they're fed up of not hearing anything back, which is a huge waste. Again, I had an interview a month or so ago, and I have no idea what I'm doing from August. It's just so tedious having to constantly.
Can I invite you in May to the Workforce Committee? Because I've specifically asked that I'd like somebody who's a relatively new recruit to come and talk to us in detail about their experience of going through the recruitment process in Jersey. I'd be very happy if you wanted to bring another person with you as well. It's a smaller meeting than this, it's not an intimidating environment, but I would be very, very pleased if you would come and talk, because I really want to go through in detail what people are personally experiencing going through the recruitment process, and therefore what we can do. I think a lot of this will be the broader system rather than HCS, but I think as non-executives we need to know exactly what is causing this, so that we can raise that and support. I know again the Minister is trying to sort these issues out as well, so that we can be supportive to try to change the system. What I would say, and I've said this to colleagues before, is when we get these issues delegated or passed back, we've got to do it well. There's no point asking for it and then doing it badly. We've got to do it really well. So listening to people's experience is going to be really, really important to us. So that's an open invitation. You don't need to respond now, but I would love you if not yourself, somebody else, it might be that you can't do that day, but if you could come and give me your contacts, I think it would be fantastic if you come and have a detailed conversation with us.
I couldn't agree more. I think it might be useful looking at, you're probably gone by then, but we also invite to that workforce committee Leslie Darwin, the Chief People Officer for the government, because some of those things might be able to be resolved from their end. But yeah, great, fantastic.
Yeah, thank you very much. I would have a conversation beforehand with you, and we will support you in that. So it's seen as being, if we're going to have the government's Chief People Officer, it has to be seen as a constructive, positive discussion about making everything better. Okay, cool, brilliant. Anybody else? Thank you for raising that. Thank you for being brave and coming and doing it as well. Thank you. Anybody else that wants to raise? Oh, sorry, I do apologise.
It's just a quick, it's a matter of clarification, and it may be Patrick, particularly about culture issues and maternity. I think we've heard that phrase a lot in the last couple of weeks, and I just wanted to understand, what does that phrase mean? What are culture issues in maternity?
I think it's about the way, predominantly about the way people interact with each other, and also within professional groups, between professional groups, respecting other people's skills, and being able to feel that you have a voice, and you can either raise concerns or put your point of view across, and it will be discussed and considered. I think that's probably the main concern that I would have, and probably the staff within the department.
And let's be clear, it's an issue in maternity areas across the UK, and it's often about midwives, doctors, the way that midwives interact with women on the wards, etc., and who listens to whom and all the rest of it. So it's not just Jersey, it's pretty common. I don't know why, but it's pretty common.
But I think, to be fair to the individuals, it's also about the environment we create as an organisation within which they work. So it's not just about the individual people, it's about what we provide for them, and a lot of the things that we've discussed today to get that right. So the appraisal, people being valued across the board, so it's not just about those individual relationships, it's about relationship with the organisation as well.
I think that's really important as well. We had a conversation about this yesterday, that people often say middle managers not great in all organisations, but what is the leadership doing to create an environment where middle managers can thrive? And it's important, it's incumbent upon everybody, and particularly the people, all of us around this table, to make sure that that's an environment where people can thrive, isn't it really? So thank you for your question. Anybody else? Well, do you know something? We're 1 minute late, and I apologise for that. But anyway, thank you very much for everybody for coming, as ever. And thank you to everybody for today's meeting. We're obviously staying for our heartbeat item, which starts at 1, so you've got half an hour for people to mingle.